Okay, perfect. So, my name is اسمي عطوان الخوري. أنا طبيب قلب لبناني، بشتغل بكندا. آم، بشكركم كلكم لأنكم you're here assisting in this session. I want to also to thank Future Vision for the opportunity they gave me to present for today. So today we will be talking about, we'll have different topics. We start now, I will present three topics. Then my colleague will present the rest of the topics. So I will present three topics. I will talk about management of patients with diabetes and hypertension first. Then we'll talk about the how chronic disease will impact quality of life of patients. And the third and my final topic will be about the use of technology in chronic care. So I will start with my first presentation, which is about diabetes and hypertension disease management. So we'll talk about both topics in details. Okay, so diabetes, as you know, we start by diabetes. Diabetes is a chronic medical condition which is characterized by elevated blood sugar levels. So glucose levels are always high in diabetes. Uh, it can be caused by multiple mechanisms. The most common one when the body does not produce enough insulin. So we have the pancreatic cells that produce insulin. In case of diabetes, we have less production of insulin, or what we call insulin resistance, uh, which means we have insulin, but the body doesn't effectively use it. Okay, so that's what we call insulin resistance. And diabetes will affect a million of people. So we have 460 million people that are affected, and we're expecting that 700 million people by year 2045 will be affected by diabetes, and which is the most prevalent health challenge worldwide. It's one of the most common chronic diseases worldwide. In the United States alone, we have 35.2 million people affected with diabetes, which is about 10% of the population, which is a very high number. And about 1.5 million of Americans are newly diagnosed every year. So each year we have around 1.5 million diagnosed, and in total we have 10% of the population that have diabetes, which is mainly related to their diet, the Western diet. So lifestyle is very important. Lifestyle management before starting the medication is very important in diabetes, because diabetes is not just a disease, it's a lifelong condition. So we're not just treating disease, it's associated with other multiple conditions. So we need to have a better lifestyle in order to treat everything alone and in order to delay the medical therapy. So uncontrolled diabetes can lead to serious health conditions like stroke, kidney disease, heart failure, nerve damage. So we can have a lot of complications related to diabetes. That's why lifestyle management plays a crucial role in diabetes care. So it's not just about taking medications, as we said. We need also to have a healthier choice in our life, like diet, exercise, stress management, and others. We have different types of diabetes. So we have the type 1 diabetes, we have the type 2 diabetes, and we have the gestational diabetes. We have also another condition called pre-diabetes. So before the diagnosis of diabetes, we're in a state of pre-diabetes, which can lead to diabetes for sure. So type 1 diabetes, it's not the most common one. It's an autoimmune condition. So we have the pancreatic cells that produce insulin. We have antibodies that comes and attack the beta cells of the pancreas. These cells are called the beta cell in the pancreas. So we have antibodies destroying these cells. So these cells will not be able to produce insulin, and that's why we will have diabetes. So we have uncontrolled glucose levels. It often comes in children's and early adolescents, so it's a disease which we can diagnose early on in life. But nowadays we can see it in later ages too. We don't know exactly why, but we're seeing more cases that are not young. So treatment was for people with type 1. Here for sure we need a lifestyle modification, but here we're obliged to start insulin in the beginning because these patients does not have insulin at all because all their cells are destroyed. So we have no choice other than starting insulin therapy. While type 2 diabetes is um, a disease that we most commonly see daily in the hospitals. So it's more common than type 1. In this case, we have the beta cells, they are intact. Don't have antibodies against them, but we have resistance to insulin from the body. So the body cells will not use insulin effectively like a normal patient, and so this will cause a relative insulin deficiency. But we have insulin, but the body is resisting to this insulin. So it's a different mechanism as compared to type 1. Usually, it showed in adults and in old age patients, but now we're seeing it more in children and teenagers, and that's due to diet and due to obesity rates because we're seeing more obese patients, especially young patients. So these patients are predisposed to having diabetes early on. In that case, the management will need to be lifestyle first. We always start with lifestyle changes, diet changes, exercise. Then, if it doesn't work, we can use oral medications and, in some cases, insulin therapy as a last stage. If you have any questions, please feel free to type them in the chat box. I'll try to answer them as soon as possible. Okay. The third type of diabetes is gestational diabetes, which occurs during pregnancy. So um, the body, it's like type 2. The body can't produce enough insulin, or we have resistance also to insulin. So, but it often resolved after childbirth, but some patients will still have diabetes even after childbirth. But most of the time, it can resolve spontaneously after childbirth. And the risk here is for both the mother and the baby. So the baby will have a high risk of developing diabetes and obesity later on in life. Especially also for the mother, she's predisposed to have type 2 diabetes later on in life. So both are at risk. Can you still hear me well? All is clear? Okay, perfect. So I'll continue. We have a condition called prediabetes. So here we're not in a stage of diabetes, but the blood sugar levels are higher than normal, but not in the diabetes range. It's a warning sign that we're at risk of developing type 2 diabetes later on in life. So we need to be careful and to start the lifestyle changes at this stage. So with lifestyle changes like diet and exercise, it's possible to prevent or delay the progression to full diabetes. So we need to act fast here, and we need to detect this stage before arriving to diabetes. So to summarize, this is a very nice table. You can see type 1, type 2, and gestational. As we said, type 1 usually occurs in young patients and babies and adolescents, while type 2 occurs in usually older patients, and gestational usually occurs in the first week, it's detected in the pregnancy, in the first trimester or second trimester. So as type 1 is like does have an acute onset, so it's a very rapidly progressive disease, while type 2 is a disease that is more chronic. It will develop over the years. We said that type 1, they don't have insulin at all. So we have insulin deficiency in type 1, while in type 2, we have insulin resistance. We have insulin, but the body cells are resisting to insulin. Usually, type 1 patients are not overweight. They are normal weight patients, while type 2, usually they are more overweight. They are often overweight, not always, but they are, most of the case, they are a bit overweight or obese. Type 1 is rare, while type 2 is very common. Most of adult patients that have diabetes have type 2 diabetes. We said that type 1 requires insulin from the start, while type 2, we can start with diet and lifestyle exercise, try to reverse it first. If it doesn't work, we can add oral medication or we can use insulin in order to treat it. Type 2 diabetes is often have family history. So when you ask a patient if his relatives have diabetes, he will say that yes, they have diabetes, they have obesity, they have cholesterol, they have heart disease. So it can have a genetic predisposition. Gestational diabetes looks like type 2 diabetes. It's very similar, but it occurs during pregnancy. And to treat it, we have to treat it with diet. And if it doesn't work, we need to start medication fast in order to limit the damage to the baby too, because high blood glucose in the mother can cause problems in the baby. So how to diagnose diabetes? So when we have a glucose less than 100 milligram per deciliter, is normal, there is no diabetes. But when the blood glucose, the fasting blood sugar, so we need to measure the blood sugar uh, in the morning before eating. When it's between 100 to 125 milligram per deciliter, this is what we call prediabetes. Here we need to detect it fast and act based on it. And when the fasting blood sugar is above 126 milligram per deciliter, in that case, we have established diabetes. Another way to diagnose it is by measuring the hemoglobin A1C, so the HbA1c levels. So HbA1c reflects, like if you want, it's an average of the blood sugar readings during the last 3 months. So when it's less than 5.6 or equal to 5.6, it's normal, there is no diabetes. Pre-diabetes is when it's between 5.7 to 6.4, and diabetes it's when it's above 6.5. So it's very important to know how to diagnose diabetes. To start, we can start with the lifestyle changes. So we said that diet is very important. It plays a crucial role in diabetes management, particularly carbohydrates, which will surely increase blood sugar levels. So to know how to manage carbohydrate intake is very important. It's the most important part of managing diabetes with diet. So we need to encourage patients to eat whole grains, so replace carbohydrate and try to increase whole grains, increase lean proteins, increase healthy fats, and eat fruits and vegetables. They provide essential nutrients and they can help stabilize blood sugar levels. Exercise is also very important. We said that we have insulin resistance. Exercise help to improve this insulin resistance and to allow the body to use insulin more effectively, and this will lead to lower blood sugar levels. So we need to tell the patient to do at least 150 minutes of moderate intensity aerobic activity, so like walking, jogging, or per week, we're talking here per week, or do 75 minutes of vigorous intensity aerobic activity per week. So depending on each patient condition, some patients can do this, some patients can do not. So we need to find a solution individualized for every patient. So the patients with type 2 diabetes, usually they have cardiac dysfunction and also they have secondary muscle dysfunction due to various reasons. We're not going into details of these reasons, but they end up having cardiac issues and muscle issues. So all of these issues will cause decreased functional exercise capacity. So even if we ask the patient to do exercise, some patients are very limited due to their condition and associated conditions. So type 2 diabetes is usually associated with decreased functional exercise capacity, and this will also increase the cardiovascular and all-cause mortality. So it becomes like a cycle. So cardiac issues will lead to diabetes, diabetes will lead to cardiac issues, and everything will lead to decreased exercise capacity. So this will not help for patients with diabetes. Other barriers to exercise in diabetes, we said usually these patients are overweight or obese, so they have decreased fitness, they have increased weight, so they tend to exercise less because of their overall condition. They have decreased cardiac and respiratory function, as we said, so tend to be more hypoxic. So hypoxic patients will exercise less as compared to normal patients. They can have episode of hypoglycemia, especially if they are on insulin. So all of this will contribute to decreased exercise capacity. Anemia is also frequent in patients with diabetes because of other associated conditions like kidney disease and heart disease. So they tend to have anemia. So they have decrease in oxygen perfusion to organs and to muscles. So this will cause drop in exercise capacity. They can have neuropathy, so patients with diabetes can have pain in their extremities. They can have problems, infections in their extremities. So this will lead to pain and loss of balance. Eyes can be affected, so we can have retinopathy as well. So loss of vision, a foot disease, as we said, due to neuropathy. So increase in foot infection and diabetic foot. So all of these conditions will lead to decrease exercise capacity and diabetes. As well, most patients with diabetes have some sort of anxiety, depression, distress, and some of them have decreased economic status. So all of these are barriers to exercise in diabetes. So it's not easy to tell patients with diabetes to follow a regular exercise habit. It's not always the case. How can exercise help in diabetes? So it was shown that moderate physical activity will cause increase in skeletal muscle glucose uptake. So the glucose that is circulating in the blood will be taken to the muscle. So we will be intracellular. So in that case, we can drop the plasma glucose, and we can drop the plasma glucose, which is very important. This is the main mechanism of exercise induce drop in blood glucose. So by increased uptake of glucose from the muscle, because when we're exercising, the muscle will increase their function, so they need more glucose. It's like the fuel for the cells in order to increase their function. So we have decreased plasma glucose. And this study is very, very interesting. It was published, it's an old study, but it's still valid today. You can see that the blue curve is for patients that exercise, that have diabetes, and the black curve is that patients that does not exercise. And you can see that for patients that exercise, so the blue curve, they have more insulin as compared to patients that does not exercise. And if you have more insulin, so it means that you will increase the glucose uptake, so will you drop the glucose level in the blood. So this study proved that exercise improve insulin sensitivity and increase in insulin sensitivity, so it drops blood sugar levels. What type of exercise can we suggest to the patient? So we need to suggest aerobic exercise, like as we said, walking, swimming, cycling, dancing. It can improve health and fitness. Weightlifting and body weight also to increase muscle and increase metabolism, because when we increase muscle, the muscle need glucose, so they will take more glucose from the blood. Flexibility and balance also exercises like other type of exercises. We're not going to details, but mainly we need to suggest walking, swimming, cycling. These are very important because they also help the heart, and weightlifting is possible. So stress management is also very important. We said that patients with diabetes have increased level of stress and depression. So this will impact also on blood sugar level. Stress, it was shown, I will show you a study later on the next slide, that stress can lead to elevated blood sugar levels. So we have a lot of techniques to treat stress. So we need to suggest this technique to the patient too. So like meditation, deep breathing exercises, and hobbies to reduce stress levels. So this is a study that I was talking about. It was published in 2019. It showed that patients with diabetes that have depression, anxiety, and stress, so if the depression increases or the anxiety increases with time and the stress increases with time, it was correlated with an increase in hemoglobin A1C level. So we said hemoglobin A1C level reflects diabetes. So you see the blue curve is increasing with the level of anxiety, with the level of depression, and as well on the y-axis, you can see that HbA1c is also increasing with the degree of depression. So it's very correlated. Stress, depression, anxiety are very correlated with the development of diabetes and with uncontrolled diabetes. Quality of sleep is also very important because poor sleep can affect blood sugar control. So we need to aim for diabetes patients, 7 to 9 hours of sleep, of quality sleep per night to support overall health. And we need the patient to be consistent, to sleep every day, like 7 to 9 hours. The study showed that around 50% of patients sleep between 7 to 9 hours, but we have a lot of patients, so around also 50% of patients that sleep less than 7 hours or more than 9 hours. So it's not good because also sleep quality um, will impact diabetes management. So why insufficient sleep can increase in diabetes? Because insufficient sleep patients usually they tend to be more obese patients. It was shown in this study. So obesity will lead to disturbances in insulin production. Also, it will lead to behavioral changes, like they will eat more, they will have bad decision making and other behaviors. So this will lead to more diabetes. So it was correlated in this study published in 2016 between insufficient sleep and diabetes. Balanced nutrition is very important. So we said carbohydrates, they significantly increase blood sugar levels. So we need to tell patient to have different sources of energy, like like eating grains, fruits, vegetables. So we need to have portion control. So we need to manage how much carbohydrate the patient is taking. So we need to measure the calories, the portions daily. Around 70% of patients with diabetes, they count their carbohydrates. They know how much carbohydrates they are eating per day, while 30% of these patients, other patients, they do not do carbohydrate countings. And in these patients, the 30%, they tend to have uncontrolled diabetes and harder to control their blood sugar level, even with medications. So carbohydrate counting is very important. And to prove it, as this study, you can see that the small blue circles are patients that does not do carbohydrate counting, while the green circles are the patients that actually do carbohydrate countings. And you can see that patients that doesn't do carbohydrate counting, so they eat without counting how much carbohydrates they are consuming, they tend to have uncontrolled hemoglobin A1C level, so they have higher hemoglobin A1C level as compared to the green circles, which are patients that do carbohydrate countings. So it's very different, and it impacts importantly diabetes. Dietary fiber-rich food they tend to stabilize blood sugar because they tend to impact the absorption of glucose. So we need to tell patient to consume whole grains, legumes, fruits, and other type of vegetables. Here is a study that's showing that patients that consume dietary fiber per day, that it shows that if we consume more fibers per day, we have decrease in mortality. You can see that the red curve is going down um, when we increase in our dietary fiber consumption in patients with diabetes. So it was proven that it drops in mortality. We said this multiple times. We need to we limit excessive added sugars. We need to limit drinking drinks that contain sugar, candies, and desserts. All of these contain a lot of sugars. We can use artificial sweeteners, so it gives a taste of sugar, but it has a lower risk of causing hyperglycemia. So this is how a diet of a diabetes patient should look like. So it need to have different type of sources. So we need to have vegetables. We need to have good carbohydrate foods like fruits. So we need to know what we're eating, and also a protein-rich food like fish, chicken, and other types of food. So the diet should look like this one for diabetes patients. Meal planning is very important. We need to tell the patient to be consistent. So we need to tell him he needs to eat every day at the same time, because most of these patients are on medications or on insulin. So we need them to be consistent. As we said, we need to add lean proteins, healthy fats, vegetables, and decrease in carbohydrates and do carbohydrate counting because we said carbohydrate counting is associated with a drop in hemoglobin A1C level, so drop in glucose levels. What if we did all of this and the patient remained hyperglycemic or the diabetes remained uncontrolled? So in that case, we don't have any other choice that we need to start using medications. We have a lot of medications used for diabetes. Before going to insulin, we have pills to take. So the most common medication is metformin. Metformin is how it works. It increases insulin sensitivity. So we said in diabetes we have difficult insulin sensitivity. So this medication will increase this insulin sensitivity. So it will allows the uh, to drop the blood glucose level significantly. It has a lot of side effects, but not very common. It can cause nausea, vomiting, diarrhea, vitamin B12 deficiency, and lactic acidosis, which is very rare. We need to be cautious in patients that have chronic kidney disease. We need to avoid it. Liver disease as well. And metabolic acidosis, we need to avoid it in these patients. One of the newest medications that we're currently using is the SGLT2 inhibitor medications. The most commonly one used is dapagliflozin. This medication will act on the kidneys. We have the SGLT2 receptors in the kidneys. So when this medication reach this receptor in the kidney, um, it will cause the glucose, it will cause a decrease in reabsorption of glucose. So glucose will not be reabsorbed to the blood, it will be eliminated in the urine. And that's why we eliminate the excess glucose in the urine. It's a very important medication that doesn't have a lot of side effects. It can cause like weight loss, increased urination. Sometimes it can cause UTI and acute kidney injuries, but it's not very commonly side effects that we see. We're using it a lot these days. We need to be cautious when the patient have renal impairment. We need to avoid it as much as possible. But it's a very effective medication because it eliminates glucose in the urine. They will not be reabsorbed to the blood, so they will go to the urine. Other type of drugs, we have these sulfonylureas. These drugs are all drugs. These drugs they stimulate insulin secretion from the pancreas, so this is how they work. But the risk here is the development of hypoglycemia. So we need to be careful, especially in old patients, because these patients, this drug can induce hypoglycemia very importantly in old patients. It can also cause weight gain. We said the SGLT2 inhibitors cause weight loss. The sulfonylureas they can cause weight gain. So it's also a bit less evident in patients with diabetes because weight gain will exacerbate the condition. Also, we need to be careful for this drug for patients with chronic kidney disease and patients with liver disease. So, side effects, mainly hypoglycemia, as we said, we need to be careful. Other drugs are the DPP4 inhibitors and GLP-1 mimetics. So these drugs are very effective as well. The DPP4 inhibitors will increase insulin secretion from the body. The GLP-1 also will cause increased insulin secretion. The GLP-1 can be given subcutaneously. So it's not just, it's given by injections. They cause mainly GI side effects, so vomiting, diarrhea. They can cause pancreatitis as well, both of them. So we need to avoid them in patients with pancreatitis, patients with heart failure, especially for the DPP4. They can exacerbate heart failure, while GLP-1 should be avoided in case of chronic kidney diseases. If all these medications if some of these medications are used and diabetes is still uncontrolled, in that case, we have to use insulin therapy. We have different types of insulin. So insulin is injected subcutaneously. We have the short-acting insulin or the rapid-acting insulin. Usually these insulins are given before meals. So we tell the patient to take insulin every day before taking the meal. So usually we give them 3 times or 4 times per day. We also sometimes give long-acting insulin, especially in long-term diabetes. So patients that are diabetic since years, they need long-term, long-acting insulin. So we call it basal insulin. This insulin will act over 24 hours, so it will stay in the body for a duration of around 24 hours. So it's a long-acting form of insulin. Um, and the rapid acting, usually it will give effect in just in 15 minutes, but it will only last for about 30 to 90 minutes. So it's not long acting. That's the main difference between both types. So long acting will peak later. So it will take time. It will not peak, but it will take time to have effect. It will take 1 hour to have effect, while the rapid acting will have effect just in 15 minutes. And the effect will not last long in rapid acting, while it will stay about 24 hours in case of the long acting insulin. So that's why we give the long acting insulin usually at night. So we give it at bedtime, we give it because the effect will last for 24 hours, while the rapid acting, we give it like 3 times or 4 times per day before or after meals. If you look on this curve, this is how insulin works. So you can see the gray curve. This is the normal insulin secreted by the pancreas. It's always present, but it will peak when the patient eats. So in patients with diabetes, we have decreased insulin. So we lose this mechanism. So in that case, we need to give long-acting insulin, so the basal insulin that will mimic the normal insulin function, so it will stay in the body all the time. And the fast-acting insulin or the rapid-acting insulin will be given at breakfast, at lunch, and at dinner to cause the surge in insulin or the peak in insulin that will drop glucose very fast in case of diabetes. So complications that can cause a lot of complications. It has a lot of complication like microvascular complication or microvascular complication. So microvascular, it affects the large vessels, while microvascular will affect the small vessels. So it can cause stroke, heart disease, hypertension. So heart disease can cause coronary artery disease. So most patients with diabetes, they tend to have some sort of coronary artery disease. It can cause also peripheral or vascular diseases, can cause foot problems, what we call diabetic foot due to neuropathy. They will tend to, they have decreased sensation in the lower extremities. And we can also have renal disease and retinopathy. So vessel in the eye will be affected. We can have retinopathy and cataracts. So we need to screen for these complications. So we have type 1, type 2 diabetes. When to screen for retinopathy, for example, in type 1 diabetes, we need to screen 5 years after the diagnosis. Then we need to continue screening annually. While patients with type 2 diabetes, we need to screen it at diagnosis. We said that these patients tend to be old patients, and sometimes they have diabetes since a long time, but we don't know. That's why we need to screen them for retinopathy at diagnosis, and then we continue that annually. We can screen also for nephropathy, same for retinopathy, nephropathy. In type 1 diabetes, we screen it 5 years after diagnosis, then annually. And in type 2, we screen it at diagnosis, and then we continue to screen annually. And how to screen, we can measure the albumin to creatinine ratio. So it's a urine test. So we ask the patient to give us urine, and we measure the albumin to creatinine ratio. And this is how we screen for diabetes nephropathy. Also neuropathy, so we said they have decreased sensation. We have neurologic problems in the extremities. So that type 1, same thing at 5 years after diagnosis, then annually. And type 2, we need to screen at diagnosis and then annually. Cardiovascular disease in both type 1 and type 2, we need to screen them at diagnosis. So hypertension and dyslipidemia, these are very commonly associated with diabetes. So we need to screen them at diagnosis. And hypertension, we need to measure the blood pressure in every visit. And dyslipidemia, we need to measure the fasting lipid profile, so measure cholesterol levels, LDL level, HDL level, and triglyceride level yearly. So each year, the patient should need to do a lipid profile. So this is a summary of all diabetes, most common diabetes complications. I just told you that diabetes patients tend to have um, significant coronary artery disease. This is the coronary angiogram. You can see here the right coronary artery of a diabetic patient. It's the coronary artery supplying the right side of the heart or the inferior side of the heart. You can see it has a significant blockage in its mid portion. So it's around a 95% blockage. So this patient was treating with a drug-eluting stent. So we put a balloon inside his artery to dilate it. Then we placed a coronary stent. So you can see the blood flow was restored, and the artery is now functioning well. But these are we see such arteries in diabetic patients like every day. It's very frequent. Okay, so I finished my presentation about diabetes. Do you have any question about diabetes before moving to hypertension? If you have any questions, I can answer them now. We can have 2-3 minutes for answering questions if you want. Okay, so I have a question from Ahmad. Ahmad is asking if type 2 can happen in a young age. Yes, we're seeing now very commonly, not very commonly, but we're seeing increased cases of type 2 diabetes in young patients. Usually this disease occur in older patients because of multiple uh, conditions, but now we're seeing it more in young patients, and that's due to obesity rates and diet. So now young patients are having a very bad diet, so I have increased risk of obesity. And we said that obesity will cause decreased insulin sensitivity. And yes, we're seeing it. It can happen at a young age too. But in young patients, usually it's type 1, but we're seeing it now more commonly, and we're seeing type 2 as well. Yeah. Yes, Wendy, if you have question, you can ask. Okay. Yes, so Wendy is asking if in menopause it seemed to also have symptoms with diabetes due to hormones. Yeah, in menopause we have some patients will take hormone replacement therapies, or these hormone replacement therapies can sometimes alter the glucose level in the body. So some patients will have a surge in glucose levels um, when taking a hormone replacement. I didn't talk about this topic, but yeah, it's a good topic. Another question by Ahmad also, are they more prone to retinopathy and other complications? Yes, as we said, we have increased risk of retinopathy as we shown in this slide, because it's a microvascular disease, so a small vessel in the eye will be affected, so it will cause retinopathy, and this can lead to loss of vision. And we need to screen, as we said here, we need to screen at diagnosis of type 2 diabetes, and then do annual tests to detect it. And we need to send the patient to the ophthalmologist to do the test. So we need to do it every year. Yes, the first presentation, it can be neuropathy, especially in patients that are not very followed up. So some patients have diabetes since 20, 30 years and nobody knows. And they tend to present with complication of diabetes as a first presentation. It's not very common, especially in countries that take care of medicine and healthcare. We're seeing less, but in countries that third world countries, yeah, we can see neuropathy as a first presentation. Okay. You're welcome. You're welcome, everyone. So now I will move. If you have any other questions, we can answer in the end too about diabetes. But now we will move to hypertension. So hypertension is also another very common chronic disease that affects millions of people everywhere. So we have recently, this year, in fact, we have the American College of Cardiology guidelines that just came out. So I'm presenting to you the most recent guidelines about hypertension. There are surprising changes because when we see these numbers, so about half of the population is now diagnosed with elevated blood pressure. So they consider now a normal blood pressure as blood pressure that is less than 120 millimeter mercury systolic or less than 80 millimeter mercury diastolic. So this is normal. But when the systolic blood pressure rises to between 120 to 129. This is not normal blood pressure. This is elevated blood pressure. And we call hypertension patients that have blood pressure between 130 to 139 millimeter mercury. So this is so a lot of people have blood pressure range between 130 to 139. So all these patients are now considered hypertension patients. And diastolic blood pressure between 80 to 89 millimeter mercury. Stage 2 hypertension, which is another severe form of hypertension, when the blood pressure is always above 140 millimeter mercury systolic or above 90 millimeter mercury diastolic. So this is very important because the therapeutic options will be based on these numbers. As you can see in the American population, so now about 49.5% of males and 43.9% of females of any age have elevated blood pressure. Not necessarily stage 1 or stage 2, but they have at least elevated blood pressure, so above 120 to above 120 systolic. So it's about half of the population that have elevated blood pressure. And even in patients that are 18 to 29, we can see 20.3% of them having at least elevated blood pressure. And as we increase by age, so between age 75 to 80, 83.7% will have any form of hypertension. So in between male and female, the same, we have the same percentage in a bit above 75 years of age. And if you look at race, so we have the white, black, Asian, Hispanic, or others, you can see that hypertension is more common in black, especially in female, because in black female, 56% of them have hypertension. And in males, it's also more common, but in females, you can see it's a lot more common because others are less than 40%, while black females in the United States tend to be more predisposed to hypertension, and these are due to genetic factors. So how to measure blood pressure in the office? It's very important because most of the time we measure blood pressure in the wrong way. So we need to verify that the patient avoid caffeine or exercise or smoking at least 30 minutes before measuring the blood pressure. So this is very important to ask if the patient took coffee or smoked before coming to the office. And also we need to make sure the patient have an empty bladder. So we need to tell him to urinate before measuring his blood pressure. We need to use a validated blood pressure machine. Not all machines are validated. And if you want to know if your machine is validated, you can visit this website. It's validatebp.org. It's very important. You can just type the information about your machine. It will tell you if it's a validated machine or not validated machine. We need to use the correct cuff size for every patient. Not all blood pressure cuffs can work for all patients, so we need to have multiple cuffs depending on the size of the arm of the patient. The patient should be the arm should be placed at heart level, so the patient is sitting, and the arm should be around his heart level. So this is very important too. The patient should be relaxed, sitting on a chair. He should not be standing. And he should be sitting for more than 5 minutes. So before measuring his blood pressure, we should not measure his blood pressure when he sits directly. We should need to wait 5 minutes. We can talk to him a bit, try to relax him before measuring his blood pressure. The patient and the clinician, the doctor or the nurse, should not be talking to the patient while measuring his blood pressure. The patient should stop talking because this can influence his blood pressure readings. It should be taken in a temperature controlled room, so also it can impact. And we need to make two or more blood pressure measurement, not just one, because sometimes one can be a false reading, so we need to take two or more, and these measurements should be separated by a 1 minute. So we don't measure rapidly because we need to make the arteries um, regain normal caliber. So we need to wait at least 1 minute apart between each measure, and then we tell the patient the reading, and we can also do the average of the readings and inform the patient verbally, and also we can do it in writing too, to document it. So when we diagnose hypertension, so let's say now we have a patient and we diagnose him with hypertension, we need to ask for blood tests to rule out secondary causes of hypertension. So we need to do a complete blood count. We need to do serum sodium, potassium, calcium. We need to do also the renal function. We need to measure the creatinine. We need to do a lipid profile because hyperlipidemia is most of the time associated with hypertension. It's a common combo. We need to also measure to screen for diabetes because diabetes, also like hyperlipidemia, can also be present with hypertension because of the diet, of bad lifestyle. So we need to measure, as we said in the first presentation, fasting blood glucose and hemoglobin A1C level. We need to also to measure the thyroid stimulating hormones because sometimes hypothyroidism or hyperthyroidism can be associated with secondary causes of hypertension. Urine analysis as well, because sometimes hypertension, especially if it present since long term, can cause microalbuminuria. So microalbuminuria is a sign of kidney disease. So we need to measure it at diagnosis. We need also to do an electrocardiogram because, as you know, long-term or chronic hypertension can cause left ventricular hypertrophy. So left ventricular hypertrophy is a thickening of the heart muscles of the myocardium, and this can be detected just on the ECG. So if you look on the heart racing, we can have signs that the patient have um, a complication of hypertension which is hypertrophic cardiomyopathy. And in that case, if we find it, we can send the patient to do an echocardiogram. So we don't ask for an echocardiogram at diagnosis. We could just start with an ECG, electrocardiogram. So if we suspect that the patient, so let's say the patient visited us in the office today and we have a reading of systolic 150 millimeter mercury. It's not sufficient to diagnose hypertension. We need to tell the patient to return home, to have lifestyle modifications, and to measure blood pressure at home because sometimes blood pressure in the office is higher. It's called white coat hypertension. When he sees the doctor, he's stressed, so blood pressure will go up. So we tell him to go at home to measure his blood pressure and multiple readings over 3 to 7 days, write the readings on a paper, and comes back to us in order to confirm the diagnosis. If the readings are similar, we can confirm the diagnosis. Same as office, we need to tell the patient how to measure his blood pressure at home. So the most important part is to use a validated blood pressure machine. As we said, this is the website that you can verify. Avoid smoking, caffeine, or exercise 30 minutes before blood pressure measurement. And as we said, the arm should be placed on a table. The patient should be sitting. It should be placed at the heart level. It can be measured in both arms, right or left arms, no issues. The patient should be sitting for at least 5 minutes before measuring his blood pressure. He should be relaxed, not watching TV, not using his phone, not talking. And he should take two readings, 1 minute apart. And he should do that twice a day. So two measures in the morning and two readings at night before sleeping. So each day the patient should write on a paper four readings, and he should do that between 3 days minimum and 7 days, which is preferred. Then he should come back and see his doctor in the clinic. All of these machines are not validated machine. You can see they can cause harm. They have no benefit. They in the guidelines, they are class 3. So class 3 is associated with harm. So these are cuffless blood pressure devices or devices that are not validated by the guidelines and should be avoided and should not be used. What are the environmental, behavioral, or genetic causes that can increase the risk of hypertension? So patients that consume a lot of sodium, so a lot of salt, that consume low potassium. So consuming low potassium and consuming high sodium is associated with the development of hypertension. Consuming low calcium or magnesium, also consuming diet that is bad, like consuming a lot of carbohydrates or a lot of fat, so we need to um, be careful. Also, consuming alcohol will increase the in hypertension causes. All these causes are modifiable causes. So if a patient have these causes, we can tell them to stop. But there are other non-dietary factors or genetic factors. So in this case, uh, especially the genetic ones, these are non-modifiable factors. We also, patients are overweight or obese, so low physical activity, sleep disturbances. All of these are not related to diet. Some of them can be modified, like physical activity or weight or sleep disturbances, but some cannot be modified, like genetic variants. So it's a combination of genetic and dietary factors or quality of life factors. So let's say we send the patient home. So we measure his blood pressure first in the clinic, then we send him home and we tell them to measure his blood pressure twice a day for 7 days. If the patient at the office have a normal blood pressure and at home he also have a normal blood pressure, in this case we can rule out hypertension. So this patient is normotensive patient, he doesn't have hypertension. But if the blood pressure is high, so above 120 or 130 in the office, and at home, it's also the same above 130. In that case, we can diagnose sustained hypertension. So in that case, we can start lifestyle modification and we can start also medical therapy. We have a rare form which is called masked hypertension. So the blood pressure is normal in the office, but it's high at home. So in that case, it's called masked hypertension. So it's not frequent, but it's associated with a lot of comorbidities too. So it's like sustained hypertension. A form that we see frequently is called white coat hypertension. So when the patient comes to the office, he a medical professional measuring his blood pressure. In that case, the blood pressure will be higher in the office, but it will be normal at home. So in that case, we call it white coat hypertension. It's just related to his visit to the office, but it doesn't mean that this patient will not develop hypertension later in life. And sometimes he can develop sustained hypertension later in life, so we need to be careful. We don't have to treat him just because his blood pressure is high in the office. We don't start therapy here, but we need to do regular follow-ups and tell him to always measure his blood pressure at home. So sometimes we have secondary causes of hypertension, like patients that have Cushing disease, which is the pituitary disease, or they have increase in cortisol in the blood. So increased cortisol will cause elevated blood pressure. Also hyperaldosteronism, though aldosterone will cause sodium retention and water retention. Aortic coarctation, this is a congenital disease, so there is a narrowing in the aorta, so the blood will accumulate before this narrowing. So when we measure the blood pressure in the upper limbs, we can see it's higher. Pheochromocytoma is also a disease in the adrenal gland. We have increased um, production of catecholamines, so it will increase in blood pressure. Also, renal artery stenosis is a very common cause of hypertension, especially in old patients, because less blood will reach the kidneys. So the kidneys will feel that there is hypovolemia. In fact, it's not hypovolemia, but it's renal artery stenosis. So the kidney will secrete renin, angiotensin, aldosterone, and this will exacerbate the condition. So, uh, when to suspect that the patient have a secondary hypertension. So if the patient have drug-resistant hypertension, so we treat him, but the blood pressure is always high. In that case, we should look for other causes. Or abrupt onset hypertension. So let's say a patient that is young is always have a normal blood pressure, but suddenly the blood pressure is very high. Or a blood pressure or hypertension at an age less than 30 is also we should always rule out secondary hypertension. Or exacerbation of a previously controlled blood pressure, so or very high blood pressure, or onset of diastolic hypertension in older adults. All of these conditions should we should suspect secondary hypertension. One other important condition is unexplained hypokalemia. So when we do labs in a patient that has hypertension and he is always have low potassium level, in that case we should suspect hyperaldosteronism, because aldosterone will cause absorption of sodium from the urine to the blood, but it will also cause loss of potassium in the urine. So When we have hyperaldosteronism, the excess sodium that is reabsorbed will cause hypertension, but at the same time, we have loss of potassium. So it's a sign that we need to look for hyperaldosteronism. So when we find any of these conditions, we need to screen for secondary hypertension. We need to screen for primary aldosteronism and other secondary form. And if a test is positive, we need to send the patient to a specialist. So if he has hyperaldosteronism or pheochromocytoma or Cushing disease, these can be seen by endocrinologists as well. So we need to send the patient to a specialist. And if we didn't find any other cause, so it's a primary hypertension, not a secondary cause, in that case, we need to optimize his medical therapy and decrease the dose or add other medications. What are the substances or drugs that can exacerbate hypertension or can cause hypertension? We can have alcohol, we have caffeine. So caffeine is very important. We need to limit caffeine intake in patients with hypertension to less than 300 milligram per day. And we should avoid more than 1 cup. So 1 cup is okay, but more than 1 cup for hypertensive patients should be avoided, and it should be less than 300 milligram per day. Some nasal decongestants, so you always need to check some nasal decongestants that contain phenylephrine or pseudoephedrine. They can cause vasoconstriction and they can cause hypertension. Some herbal substances. One of the most common cause of hypertension is NSAIDs, so non-steroidal anti-inflammatory drugs. These drugs are used for pain, so these drugs can cause hypertension. That should be avoided in patients with hypertension and replaced by other substances. Some antipsychotics and antidepressants also can cause hypertension, especially the old generations. Immunosuppressant drugs like cyclosporin, which is used as a for renal graft patients or other graft patients or bone marrow transplant patient, it can cause hypertension. Oral contraceptive also, so hormone replacement therapy or oral contraceptive can also cause hypertension, and we should suggest using a low dose, like using 20 to 30 microgram of ethinyl estradiol in that case, and we should avoid them in women that have uncontrolled hypertension. Systemic steroids as well, which are very frequently used by patients for various conditions like prednisone. These medications are associated with higher blood pressure. One of the most common cause of secondary hypertension that we didn't mention before is obstructive sleep apnea. So obstructive sleep apnea is when we have blocked airways during sleep. So these patients tend to have also associated endothelial dysfunction and increased arterial stiffness. So increased arterial stiffness will cause the vessel to be less reactive. So in these patients, we have higher blood pressure. And if you look on the blue, we have two blue curves, one dark blue and one light blue curve. The light blue curve is for patients that doesn't have sleep apnea. They have lower blood pressure levels, while the dark blue curve is for patients that have obstructive sleep apnea, and they tend to have a significantly increase in blood pressure. And the treatment of obstructive sleep apnea is very simple. We need to diagnose it by a sleep study. So we do a polysomnography. And then if the test is positive, we need to put the patient on CPAP machine. So it's a continuous positive airway pressure machine, the CPAP, which will help open the airway during sleep in order to avoid the apnea events. In that case, even without medication, just using CPAP, it can drop the blood pressure significantly. So the lifestyle changes is very important before going to diet. So we need to tell the patient he need to lose more than 5% of weight, especially in case of overweight or obese patients. We need to tell them to lose around 5% of weight. We need to use a healthy diet, so avoid fat, avoid carbohydrates. We need to use less than 1,500 milligram per day of sodium. We need to limit alcohol or avoid alcohol. We need to increase potassium. We said we should drop sodium and increase potassium if possible. And we need to exercise, like doing aerobic exercise like walking, swimming, or jogging is very important. So why is this? Why we say that we need to lose weight? Because this study showed that losing weight alone would drop blood pressure between 6 to 8 millimeter mercury in patients that have hypertension. So it's a significant drop. And if it's associated with decreased sodium intake, we have another 6 to 8 millimeter mercury drop by just decreasing sodium to less than 1,500 milligram per day. So diet is very important. You can at least drop your blood pressure by 10 to 20 millimeter mercury if you follow all the diet guidelines to drop the blood pressure. Also, increase potassium intake can drop the blood pressure by 6 millimeter mercury. Decrease alcohol use, it can drop it also by 6. Doing exercise, any form of exercise can cause a drop between 2 to 8 millimeter mercury. So, as you can see here, lifestyle changes can significantly drop blood pressure in various conditions, but it's not always possible due to limitation of from some patient from obesity. They can't exercise. Sometimes they can't change their diets. It's not always easy. In that case, we don't have a choice other than starting them on medications. So when to start medications? So any patient that we confirmed has high blood pressure in the office and at home, he has a sustained blood pressure of above 140 millimeter mercury systolic and 90 millimeter mercury diastolic. In that case, we should initiate antihypertensive medications. And now we say it's better to start two medications at the same time, not just start with one, add two in the beginning. If the patient have blood pressure less than 140 systolic, in that case, we need to see if the patient have any other cardiovascular disease like coronary heart disease or stroke or heart failure. In that case, the threshold becomes to start therapy becomes 130, not 140. So if a patient has a blood pressure of 130 millimeter mercury and have heart disease, we need to start him on medication to treat his hypertension. Or if the patient have chronic kidney disease, same thing, the threshold becomes 130 systolic to start the blood pressure medication and not 140 like any other patient that doesn't have cardiac disease or kidney disease. So start blood pressure medication if the blood pressure is above 140 to 90 in any patient, or when it's above 130 systolic in patients that have cardiac disease or chronic kidney disease. So you just need to memorize these two numbers, 140 and 130. So as we said, it's better to start a combination of drugs, two drugs in the beginning, and the recommended drugs now are thiazide diuretics, angiotensin converting enzymes, or angiotensin receptor blockers, so ACE inhibitor or ARBs. Also use calcium channel blockers. So any two from these three that I just mentioned should be started at the beginning. These are the example of thiazide type diuretics. So we have the chlortalidone, the hydrochlorothiazide, and the indapamide. Hydrochlorothiazide is the most commonly used diuretic to treat hypertension. It has 25 to 50 milligram dosages. We also have the ACE inhibitors, the ARBs, or the calcium channel blockers. You can see that all ACE inhibitor will end with pril. So you see all of them will end with pril. All of these are ACE inhibitor, and ARBs, they will end with artan. So all of these are also ARBs. It's very important. You should not combine ACE inhibitor with ARBs. It's contraindicated. It can cause significant kidney disease because both of these drugs will act on the kidney level. So it's absolutely contraindicated to use them together. Should be avoided. You can combine the thiazide diuretic with either of ACE or ARB or with CCB. You can also combine calcium channel blocker with ARB or with ACE or with thiazide. So you can combine multiple combination, but the combination should not include ACE inhibitor and ARBs at the same time. So this is very important to avoid. If the patient we used all these drugs and the blood pressure is still not controlled, we can use other drugs like beta blockers. We can use also alpha blockers. So we'll not go in the details of each drug, but you should know that we have a lot of drugs. We have second lines, we have third lines, so we always can add drugs in order to control the blood pressure. So we need to make sure that sometimes we can find a single pill that contains two drugs at the same time. This will increase in compliance because some patients, for sometimes when we tell them to to take multiple medications. Sometimes they forget some doses, they skip doses. So if we find a pill that contain a combination of drugs, this will be the ideal situation. And we have now a lot of pills that contain two drugs and three drugs combination. So it's very advised to use these combination single pill. So they take it once a day, but this pill contains 2 to 3 drugs. This will increase compliance of the medication by the patient, and it will lead to more control of his blood pressure. So let's say we started the medication today for a patient that we diagnose with hypertension. We put him on a combination of therapy, 2 drugs. We need to tell him to come back to see us in 1 month. If and at 1 month the blood pressure goal is not met, so the blood pressure is still above 130 or above 125, let's say, in that case, we need to intensify his medical therapy. So we need to add a third medication. We need to increase the dose of the first 2 medication. So we need to make sure he's taking the medication at the correct time or as prescribed. He's not skipping doses. And if the patient comes with a controlled blood pressure, so the blood pressure that drops below 130, in that case, we are reassured and we tell him to come back to us in like 3 to 6 months. And we reassess again. So the first visit should be 1 month after starting the drugs. And if the blood pressure goal is at target, we tell him to come back at us in 3 to 6 months. Okay. So what if the patient have resistant hypertension? So what is resistant hypertension? Resistant hypertension is when the blood pressure is always high, above 130/80 millimeter mercury, and the patient is on 3 or more antihypertensives that should include a diuretic. So they are either on combination of ACE inhibitor and CCB and thiazide-like diuretic, and the blood pressure is still uncontrolled. In that case, we need to maximize the diuretic therapy. So we need to increase the dose of the thiazide, or we can replace the thiazide diuretic by another diuretic like chlortalidone or indapamide. And also we can add a fourth drug, which is spironolactone, which is a mineralocorticoid receptor antagonist. It has 2 doses, 25 and 50 milligrams. This drug is very effective in reducing blood pressure because it blocks the aldosterone secretion from the kidneys. We said aldosterone will cause increased sodium reabsorption, so we block the sodium reabsorption, we decrease the sodium. But we should be careful with this drug and we should avoid it in patients that have an altered kidney function. So we should avoid it when the GFR is less than 45. We only should use it when GFR is above 45. Also, we can add beta blockers, like we said. Beta blocker they tend to use them before for hypertension, but now these days we avoid using beta blocker as a first line for hypertension. We sometimes use them for hypertension, especially if the patient have fast heart rates, because beta blockers will drop the heart rate and it will cause a more modest drop in blood pressure. So we don't use them as first line, but we use them in case of resistant hypertension, especially in patients that have heart failure or patients that have tachycardia. So we have a lot of drugs that we can use in this situation. Another interesting topic for resistant hypertension. So we tried all the medications and the medication are failing. The blood pressure is always high. We eliminated secondary cause of hypertension. So what to do? We have a procedure what we call renal artery denervation. So it's a minimally invasive procedure. We go by the femoral artery. We put a needle in the femoral artery. We advance a catheter. We go up and we reach the renal arteries. Then when we reach the renal artery, we use a high radio frequency energy. So this radio frequency energy will try to will ablate or will destroy the nerves surrounding the renal arteries. And these nerves function is to moderate the blood pressure. So we see that this patient can have a decrease in their blood pressure when we do this procedure. So it's not used frequently, but it's used like a last resort when everything fails. Last slide about hypertension. So sometimes patients come to the emergency room with what we call hypertension emergency. So hypertension emergency is when the blood pressure is above 180 systolic and above 120 diastolic. Most of the time, this condition is associated with end organ damage. So the patient can present with a stroke. It can present with a myocardial infarction, so a blocked coronary artery. It can cause aortic dissection and can cause pulmonary edema because when you have a very high blood pressure, the heart will pump against a high blood pressure, so the heart will not be able to pump, so all the fluid will accumulate in the lungs, and the patient will present with acute pulmonary edema and dyspnea just due to elevated blood pressure. It can also cause acute kidney injury, or if the patient is pregnant, it can cause eclampsia and abortion. So all of these are and organ damage caused by very severe hypertension. What to do now when we have a hypertensive emergency? We need to admit the patient to the intensive care unit or the CCU or ICU, so he need to be monitored. We need to eliminate aortic dissection or a pherocytoma crisis because aortic dissection is a emergency, so we need to treat it rapidly. If we have aortic dissection, we should drop the blood pressure to 120 millimeter per mercury very fast. We need to use IV medication to drop it to less than 120. And if we don't have aortic dissection, we don't have to be very aggressive. We need to have a target to drop the systolic blood pressure by 25% in the first hour. So we need to target a blood pressure of 160 within an hour after arrival to the emergency room, and then drop it to normal within so starting 6 hours to 48 hours. So we don't have to be very aggressive with dropping the blood pressure in case of hypertension emergency. We should drop it gradually. We only have to be aggressive when you have aortic dissection because aortic hypertension, aortic dissection will exacerbate the condition and is high risk of death in this case. Okay, so that was my presentation about hypertension. If you have any questions, we can answer them now. Please write them in the chat box. Okay, clear for everyone, no questions? Very good. Okay, so now we'll take a 5 minute break and we'll continue with our second lectures. If you have questions, you can write them in the break. I'll be here. And see the slide. Okay. Okay, so I'll start my second presentation, which is about the quality of life in chronic disease patients. We talked in the first presentation of two of the most common chronic diseases, which are diabetes and hypertension. And now we will focus more on the quality of life in these conditions and in other conditions as well. So how to define a chronic disease? So a chronic disease is a long-term medical condition that takes years. It's progressive. It it persists in at least 3 months or more, and it's not preventable by vaccines or it's not cured by medications. So we can't, for example, prevent hypertension with a vaccine until now. Maybe in the future, yes, but till now we don't have a prevention. And even the drugs that we use, they do not cure hypertension. They just drop the blood pressure, but we're not treating the cause. We're just treating the endpoint, which is the high blood pressure, but we're not treating really the cause of this condition. So all chronic conditions are similar in this aspect. And they will often require ongoing medical attention, so frequent consultations, and all of these conditions, they will limit activities of daily living. Some examples, so diabetes, hypertension, as we said, heart failure, coronary artery disease, cancer, chronic respiratory disease like COPD or asthma, chronic kidney disease, all of these conditions are uh, chronic diseases. Other conditions include Alzheimer's disease, arthritis, liver disease, so mental health, obesity. So all of these, you see them every day in all specialties. If you're a doctor, a nurse, or any other healthcare worker, so you will be facing any form of chronic diseases. Risk factor of chronic diseases include age, so family history. If the patient have a family history of diabetes, for example, he is predisposed to have diabetes, poor diet, lack of exercise, smoking, alcohol consumption, exposure to pollutants like toxins or environmental exposures, chronic stress, lack of sleep. So all of these are factors that can be modified. Some factors can't be modified, like genetic factors, which are the risk factors. In that case, we have no choice. We can't modify them. So if you look here on this study, you can see that this is a Canadian study. It's published by the government of Canada. So you see that patients that have above 65 years of age, 73% of these patients or these individuals have a form of at least one chronic disease. So at least one of the 10 most common chronic diseases, so 73%, imagine, it's a big number. So almost everyone have a chronic disease. The most common chronic disease in Canada is hypertension. It's found in 65% of patients that are above 65. Um, Periodontal disease also, osteoarthritis found in 38%, ischemic heart disease found in 27%, diabetes in 26% of Canadians above 65, osteoporosis 25%, cancer 21% of individual above 65, so a big number. COPD, asthma, and mood disturbances also found in less percentages. But at least 73% of Canadians above 65 have at least one of these 10 conditions, and some of them have multiple ones. So the risk factors, so we said that there is risk factor to in order to have all these chronic conditions. So 9% they use tobacco use every day. 77% they consume less than requested fruits and vegetables. And 60% they do not exercise, so they are always sitting or sleeping. 8% they consume high-risk drinks or caffeine or alcohol or any other sort of um, consumption. And 28% to 30% they are overweight or they have abnormal BMI. And 46%, so around 50% of these individuals above 65, they have trouble in sleeping. So the risk factors are very frequent in this age population due to various factors. If you compare these chronic conditions between women and men, you see some of them are more frequent in women, like osteoarthritis or osteoporosis. So these are bone diseases. They are a bit more frequent in women. Dementia also a bit more frequent in women, while other conditions are more frequent in males, like hypertension. Ischemic heart disease is more frequent in male. COPD is more frequent in male. Diabetes as well. So we have a lot of variability, or all of these variabilities are related to genetics mainly. So according to the WHO, so chronic diseases, it will account for the majority of deaths worldwide. So 70% of deaths worldwide are related to non-communicable diseases that are chronic diseases. So non-communicable disease, we're not talking here about infections, we're talking about cancer, hypertension, diabetes. So 70% of the deaths are related to these non-communicable chronic diseases. If you look here also on this study, it's the same study from the government of Canada. You can see this study is about the incidence of cancer and mortality in cases of cancer. So you can see that the most common cancer in Canada is the lung and bronchus cancer. It's found in each year we have 32,000 patients diagnosed with cancer each year with lung cancer. Then come breast and prostate, colorectal, and the list is very big. We're not going to talk about all the types of cancer, but you can see the numbers, and you can see also the death rate, the mortality rate, or also the lung is the most common cancer that will cause mortality. So we have 20,000 deaths each year due to lung cancer. And in total, all the cancer will cause, will have 88,000 deaths, incidence of deaths each year related to cancers. So imagine the economic costs of having cancer to the healthcare system. So around 3.5 million Canadians they also live with diabetes. So we talk about cancer, now we're talking about diabetes. And in year 2000, there was only 1.3 million. So there is a big rise in diabetes diagnosis in Canadians over the years. So these conditions will not only increase healthcare costs, but will also have long-term effect on workforce productivity, family dynamics, and community resources. So all these patients will not be able to work. So they will cause a loss of productivity for all the society. So the cost of cancer is expected to be nearly 174 billion dollars by year 2030, and the direct and indirect cost of diabetes are expected to be 312 billion dollars each year, which are very significant numbers. So if you see here for diabetes alone, so here now we're talking about Americans, we have 30 million Americans that have diabetes. And we have 84 million that have prediabetes that are predisposed to have diabetes. So the cost of the yearly medical cost of visits and doing the blood test and everything will cost $237 billion each year. And also these patients will not be able to work, will not be productive. So here also we have a $90 billion loss. So in total we have more than $300 billion loss every year from this condition. Same for our high blood pressure. We have 78 million American diagnosed with hypertension. So this will cause a loss of $131 billion from lack of productivity, from the patient will not be able to work, will retire early. And also it will cost around $200 billion for just doing the test and doing the visits and everything. And it's associated with a lot of death rates as well. So quality of life is very important in these patients because we don't just care about survival. We need also to care about how to enhance the quality of life, which is a primary goal in managing these chronic illnesses. So we need to focus on physical comfort, of emotional well-being, social connectedness, and the ability to perform daily activities. And we'll develop these things. So what is quality of life? We always hear about quality of life, but what is exactly quality of life? So quality of life, it refers to the individual's overall well-being. So it has a lot of parts. So it has physical, psychological, and also social aspects of health. Uh, so it's a very complex system that have a lot of factors, a lot of conditions, we don't just need to focus on one condition. We have the physical, we have the psychological, and we have tools to measure the quality of life. So in order to be standardized and everyone who talking on the same page, we have tools that we'll see and later on in this presentation, how to quantify quality of life. We have a score, we have tools in order to do it, and we'll see that. So the physical well-being is the level of independence, energy, pain management, and ability to perform daily activities. We have also the psychological well-being, which is the mental health, emotional balance, life satisfaction. We also have the social well-being, so the relationship, the family, social support, how the patient is participating in his community and in his family, financial stability, access to resources, and living conditions. All of these are domains that are subdomains in quality of life. So we need to recognize and address all of these domains in order to help our patients, in order to improve their health, because a patient that has a good quality of life will have he will respond to treatment and he will be adherent to treatment more than patient that has a poor quality of life, for example. So the burden of chronic diseases, we said that chronic diseases affect billion worldwide, and each year this incidence is going up because the population is aging. So the lifespan of humans are increasing. So we are diagnosing more and more chronic diseases due to age and also due to lifestyle changes, mainly diet and lack of exercise, and also urbanization, so pollution, lack of exercise, and all of these factors together. This will increase demand for long-term care, and it will cause frequent hospitalization and frequent medical assistance. So, as we said in the beginning, around 73% of individuals above 65 in Canada, they have at least one of the 10 common chronic diseases. So, it's a very big number. So we said it will have significant healthcare costs. It will increase will increase the spending on health. It would cause long-term disability due to high expenses. So it will cause strain on families, communities, and also national health care budgets. It will increase taxes. It's all related. So what is the most common physical impact of these chronic diseases in quality of life? So we see a lot of pain and fatigue in patients that are hospitalized. Especially patients that have cancer, for example, they tend to have a lot of pain and fatigue due to different factors. So this will impact their physical capacity and also psychological well-being. So a patient that cannot move, cannot do his activity alone, he will be psychologically down as well. So it's common in chronic conditions, as we said, cancers, heart failure, diabetes, COPD, rheumatoid arthritis, and other inflammatory diseases. It also can be a side effect of therapy. So, for example, chemotherapy or radiation therapy, they can cause fatigue very frequently. So we should be careful about this aspect of these drugs, and we should prevent it. We need to manage pain. We need to include medication to treat pain. We need to include physical therapy and alternative therapies as well. And we need to address pain early on in order to prevent further complication because a patient that has fatigue or has pain, he is at increased risk of falling or fractures. So we need to use medication when possible. We should not avoid using medication. To the opposite, we should use medication to treat pain. We should not keep the pain. So we talked about cancers that can cause fatigue, but what is the mechanism of fatigue in cancer? As you can see here, it's multifactorial. We have different causes of fatigue in cancer. Mainly, cancer patients are usually anemic and have some sort of malnutrition. So anemia, you have decreased oxygen circulating in the blood. So tissue and muscle and extremities will have, and the brain also will have a decrease in oxygen. So this factor will cause fatigue on the long term for these patients. Also, the cancer will increase substances and cytokines and inflammatory markers that will promote fatigue. As we said, chemotherapy and radiotherapy and surgery, these are very frequent causes of fatigue in cancer patients. Psychological factors, if you see cancer patients, most of them have anxiety, have depression, so this will also induce fatigues. Treatment of depression, also the antidepressants and all these medications, they can cause also fatigue as a side effect. So it's a multifactorial cause of fatigue in cancer patients. So when you have more pain, patient will not move, they will rest more, they will reduce their activity, and they will reduce their muscle strength, and it becomes a cycle. So more pain, decreased productivity, more fatigue. So it's like a cycle that's cycle by stopping the pain. Also, a lot of these patients have functional limitations, so they have difficulty walking, not just pain. So they can't walk, they can't climb stairs, they can't dress themselves, they can't perform their daily house activities. So they always need assistance from a caregiver or from a family member. So the family member is also impacted in this case. It's not only the patient, because the family member will have fatigue and he will need to take care of the patient. So it's not easy on the family members too. So the patient will not be independent in his daily activity. So he increase reliance on healthcare services or on a family member. So it's mainly due to deconditioning because of decreased activity, and it becomes a cycle. and the cycle will keep going. So as you said, you need to break the cycle at a point. We can suggest the patient to use devices that help him walk. We also have patient lifters for patients that are completely immobilized, as you see in the picture. In this picture, this lifter will help move the patient from a supine or sleeping position to a sitting position, and this will decrease the burden on healthcare workers or on family members too if we provide these devices to the patients. But for sure, this will be at an increased cost of the economy as well. So this is the cycle that we talk about. So a patient that have impaired physical function, this patient will reduce his daily activity. So he will lose muscle and bone strength as a result, and this will also lead to a fracture and pain. So, and when we have fracture and pain, the cycle will restart. The patient will have impaired function, reduction activity, loss of muscle, bone strength, and more fractures. So it's a cycle that we need to break. And also psychological and social factors, they come inside this cycle. So they increase the impaired physical function, they increase the daily activities if we have more stress and more depression. Sleep disturbance is also very important in patient with a chronic condition. We said that when we talked about diabetes, we said that patients with chronic condition should sleep at least 7 hours to 9 hours. So we need to be careful at this aspect because it will cause a lot of complications later on. This is a nice study published. It's a meta-analysis published in 2022. It grouped multiple studies performed in Australia, North America, Europe, and Asia. You can see that around 1,457 patients from Australia. All these patients have cancer. So around 57.9% of these patients have sleep disturbance. So it's a very high percentage. Same applies to North America, Europe, and Asia that have around 60% of all cancer patients that have any form of sleep disturbance. So it's above 50%. So it's a big number in all cancer patients, and this is due to multiple factors, mainly due to psychological factors. So the psychological impact is very important, as we said. You have the depression and the anxiety. It's common due to the patient is uncertain of his disease. He doesn't understand well the disease. He doesn't understand the plan. He's physically limited. All of this will cause depression and anxiety. Stress also, because he always self-monitor himself, like in diabetes, he's always measuring his glucose, he's always measuring his blood pressure. He is always on multiple medication. You see patients that have a list of more than 10 medications to take every day. So all of this will cause stress. Frequent hospital visit will also cause some emotional strain. The patient see himself, he is unable to move, he lost his old lifestyle. So all of this will also cause psychological disturbances. He is always afraid that the disease will progress. So it's the same thing. Also, cancer patient, for example, they have change in physical appearance, so they lose their hair, they are unable to work, they were independent, now they are not independent, they need someone to take care of them. This will cause reduced self-esteem and self-worth, leading to psychological impact as well. So we need to focus on each point and it need to be individualized for each of our patient, and if needed, we need to send the patient to a psychologist or a psychiatrist in order to treat the underlying condition. So all of these conditions are associated, like diabetes, hypertension, dementia. All of these diseases, they can cause physical inactivity. So physical inactivity will lead to obesity, and inactivity and obesity will lead to depression. And depression, in turn, will also lead to physical inactivity, to obesity. So it will exacerbate diabetes, hypertension, heart failure, and dementia. So it's like interaction between all of these factors that will impair the quality of life. So diabetes, because we talked a lot of diabetes, let's focus a bit on how can diabetes lead to depression. So the stress of daily diabetes management, so the therapies, the insulin injections, um, difficulty keeping the blood sugar control. He can't eat like he wants. So this will cause increased tension between the patient and his doctor too. It will cause fatigue, exhaustion, and difficulty making dietary changes. So this will lead to depression, and depression in turn will cause a change in appetite. Some patients that are depressed will tend to eat more. They have suicidal thoughts. There are nervousness, anxiety, loss of energy, and all of this will lead to an increase in cortisol level. Increase in cortisol level will cause hyperglycemia and will impair insulin sensitivity. So it will also lead to diabetes. So it becomes a cycle. Diabetes leads to depression, and depression leads to diabetes. This is also applies to other form of chronic diseases, to cancer, to other forms, not necessarily just to diabetes. You can apply this also to other form of chronic diseases. This is a very interesting study. It was published in June 2022 about in a journal called Current Problem in Cardiology. This study is about studying the rate of depression and heart failure patients. You can see that multiple centers from different countries are included. Uh, in fact, Saudi Arabia was included too. And in Saudi Arabia, for example, they studied 1,200 patients with heart failure, and they detected that 67% of these patients have a form of depression. It can vary from country to country. You can see in Greece, for example, 90% of heart failure patients have a form of depression, while, for example, in Denmark or Ireland or Singapore, these countries they only have 20% of depression in heart failure patients. Uh, we don't know why exactly it changes from country to country, but there's a lot of factors that can influence for sure. But you can see that depression is always present in a heart failure patient, and the percentage ranges from 20 to 20% in some countries to 90% in other countries. And in Saudi Arabia, so in the Gulf countries, we have around 67% of patients with heart failure that have depression. So social impact as well, the patient will be isolated, so he will feel isolated because he's unable to perform his physical activity, his daily physical activity. He's embarrassed about his condition. Also, as we said, it will impact family members because his family members will care of the patient. So this can affect family dynamics. So let's say um, a patient and his wife used to work. Now she is unable to work. So there is loss of productivity because she needs to take care of um, her husband. So, or the opposite can apply too. Um, there is also work and productivity challenges, as you said, not just for the patient, but also for the family member. The patient can lose employment. This will cause financial instability. Also, we have reduced social participation, so the patient will be unable to engage in his usual hobbies. He's unable to travel, so to decrease life satisfaction. Also, so all of this will affect quality of life in a bad way. So, and all of these conditions are present in different form of chronic diseases, in all form of chronic diseases as well. So we said in the beginning, we have tools to measure quality of life. So it's not just we're not just here talking about something that is qualitative. We can we can quantify it. So we can measure quality of life, and we have different scores. So we have more generic tools that can be used to all chronic diseases. We have the SF36 score. I will show you the score. It has 8 domains, so it includes physical, functional, bodily pain, and general health. And you calculate the score, and based on the score, you know at what stage is the patient. There's another score which is the WHO QOL BREF score. Also, another score that here it includes physical health, psychological health as well, and social relations and environment. So it includes other factors too. For heart failure, for example, we have the Minnesota score for heart failure, and for diabetes, we have the diabetes QOL measure. So we have different score depending if you want a general score for all the tools, you can use the SF36 or the WHO QOL, Or for heart failure specifically, we have the Minnesota, and for diabetes, we have the diabetes QOL. So this is the SF36 score. As you can see, it includes multiple conditions, and each condition also have sub-conditions. So for example, physical function, I didn't detail it here, but I'll just show you the main points. But the patient will get a score for each of these factors. And at the end, if the score is between 80 to 100, the quality of life is excellent. If it's between 60 to 79, it will be good. 40 to 59 to be moderate, and 20 to 39 will be poor, and 0 to 19 it will be very poor. So we are now quantifying quality of life, not just talking about it. Same for the WHO QOL, the second score that we talk about. It's important here that it includes psychological health, not just physical health, social relationship, and environmental. So this is more like a more general score because it's not just about the patient, also about the social relationship, the environment, the physical, the psychological. So as well, we give points to each of these factors, and the higher the score, the better the quality of life. So 16 to 20 is very good quality of life, while 4 to 7 is very poor quality of life. So this is the Minnesota we said this is for the heart failure. Sorry, this is for the heart failure score. So also it contains physical dimensions and emotional dimension, and at the end we have the total score. Here in this score, the lowest the score, the better is the quality of life. So as the opposite to the other scores, and if the score is above 60, so here we have a severe quality of life impairment. So what are the factors that can influence quality of life, as we said? So it's like a summary. So disease severity, so more advanced stages like cancer, if he's in end stage, for example, for sure, the quality of life will be affected a lot more than a patient that is in early stage cancer. Comorbidities, like present of different comorbidities at the same time, will exacerbate the condition. Also, low income patient or low education level patient or patients living in poor conditions and poor health condition. So these are the socioeconomic status. Also, they can affect quality of life. The access to healthcare. So some patients does not have access to healthcare due to lack of insurance or lack of money. And also sometimes they live very far from the hospital. So they live in rural areas, so there's no access to hospitals. Some patients does not understand what their condition, so we need to educate patients. We need to teach them about the condition, not just give them medication. We need to explain how the disease is affecting them, why they have the disease. So this will reassure the patient when they understand what they have. And also we need to have support, because strong support from families or other healthcare providers will influence quality of life. So it's like a teamwork that contains team members, physicians, nurses, psychologists, physiotherapists, occupational therapists, dietitian, and pharmacists and social workers. They always need to act together in order to improve the quality of life. So in a good hospital, in a good respectable hospital, it needs to have a plan for chronic disease patients. All of these specialists should be involved. Psychologists, especially, is very important to involve them in cancer patients, because the vast majority of cancer patients have psychological disturbances. So we need to do regular team meeting, discuss this case, discuss how our patients are progressing, try to change the plans if the patient is not progressing well. We need to focus on physical symptoms as well as on mental health, lifestyle changes. Also, we need to set a goal, set a plan for the patient, and be sure that the patient is following our advices. So nutrition is very important. You need to have a balanced diet. So here the dietitian is will have a very important role, especially in heart failure. For example, you need a low sodium diet, because uh, if you increase sodium, you will increase water retention, so there's a volume overload. Physical activity, very important. So part of lifestyle, we need, as we said, to have around 150 minutes per week of physical exercise. Smoking cessation, alcohol moderation, sleep hygiene. Also, try to decrease caffeine consumption. All of this will be included. These are the example of the diets. So you can see that, you can see that we have two healthy diets, which are the Mediterranean diets and the vegan diets. Both of these diets are rich in fruits, vegetables, and grains, nuts. They both can promote anti-inflammatory effects, so they lower the risk of chronic diseases. They improve insulin sensitivity, and also they lower the obesity. And they both have a protective and positive effect on the heart health and on chronic diseases. As compared to high-fat diet and Western diets and ketogenic diet and high-carb diets, these diets should be avoided in chronic disease patients because they increase the risk of obesity and increase the risk of cardiovascular diseases and other cancers also. So we need to try to advise the patient to follow a Mediterranean diet or a vegan diet. So a diet that is rich in fruits, vegetables, and whole grains. This is very important uh, to improve his health. Psychological support also, so counseling. You need to tell the patient to go see a psychologist or a psychiatrist, do cognitive behavioral therapy. So try to do not just give him medications, but try to talk to him, reduce his anxiety. Sometimes in group meetings with other patients at the same time that have a similar condition, this can the patient will not feel alone. So it's very important. A lot of techniques can be used, but this need a specialist and psychologist. So sometimes we have to use medications, like when the patient have pain, we need to use analgesic and anti-inflammatories drugs. We need also to use some specific modifications to reduce the discomfort. So like treat depression, treat anxiety, stop the pain. We need to manage comorbidities also, so treat hypertension, diabetes that are associated with the disease. We need to educate the patient in order to the patient become more adherent to his therapy. And we need to always continue monitoring the condition to check if the patient is um, taking the drugs as prescribed and to minimize the side effect and to adjust the dose. So we need to educate the patient in order to improve his condition. Some physician or healthcare workers they use telemedicine, so we can do video consultation, use mobile apps in order to follow up on patients. So the patient, because the patient cannot move because of his condition, he's has pain, fatigue. So it's not always easy to make the patient come to see us in the clinic. So sometimes we use telemedicine. We just talk to the patient on the phone or do a video consultation or use apps, for example, to track his vital signs, his blood pressure, his glucose level. So all of this will decrease the disease burden on the patient, and the patient will feel more relaxed staying at home. We should use this more and more. Also, rehabilitation programs can be used, especially cardiac rehabilitation and pulmonary rehabilitation. So there are programs used for these patients, especially after a big event like a big heart issue or a big pulmonary issue. So this patient can benefit from cardiac rehab, for example. It can enhance the recovery. And it's also the cardiac rehab, for example, can lower the chance of another heart attack or heart surgery or can decrease the future hospital admissions. This was shown in different studies. It can decrease the pain, can decrease the symptoms, and decrease the need for medication. And during the rehab, the patient will be managed. So they will treat his high blood pressure, his cholesterol. They will try to drop his weight, and they will educate him on how to have a healthy life. So it's recommended for all patients that have a heart attack or heart surgery or heart failure. And you can find different programs in different hospitals. Oh, it's very recommended. Same for pulmonary rehabilitation. So COPD, as you know, chronic obstructive pulmonary disease is the third leading cause of death worldwide. So above more than 60 million of people are diagnosed each year in the US. So doing pulmonary rehab in this patient will improve outcomes. So it will increase exercise capacity, increase quality of life, and decrease future COPD exacerbation later on. So as a case, I will show you a case of a patient I saw. He's a 62-year-old male with advanced COPD and diabetes. So he will always have breathlessness. He's always needing oxygen. He can't move. He's depressed. He's financially stressed as well. So we send this patient to pulmonary rehab. with nutritional counseling to change his diet, with cognitive behavior therapy session for his stress, and also telemonitoring. And in few weeks, the patient has improved exercise tolerance, reduced anxiety, and his blood pressure was stabilized, and blood pressure was stabilized, blood sugar as well. And he is now have increased social participation. So this shows that why rehabilitation is very important in chronic diseases. We have some challenges. We have sometimes we have limited resources. We don't have healthcare infrastructure. Not all hospitals are equipped, especially hospital in rural areas. Some patients are not adherent, so they will not follow the recommended medications. They will have more side effects. Um, some does not understand how the disease is progressing or why they have the disease, so they tend to be less compliant. And so this is mainly as a summary of the challenges that we are facing to improve the quality of life in chronic disease. In the future, what can be used? So we can use personalized medicine. So we can't apply all these things to all patients. Each patient should be like a different patient as compared to others. So each patient should have different treatment goals to improve the quality of life. We'll have more use of artificial intelligence in these patients. We'll assess more and more the quality of life with the score that I showed you. So we'll quantify it. Yeah, so that's it. So this was my last slide. These are my reference. If you're interested to read more about this condition, you can check the WHO website, the CDC website, and other studies that I showed you during this presentation. So thank you for listening to this topic. Now at, uh, we'll come back in 6 minutes. So if you have any questions, please let me know in the chat. Thank you for listening. So we will be back in 5 minutes for my last presentation. You're welcome, everyone. If you have any questions about the two topics, we can answer them now. I have 5 minutes. Can you see my slides and can you hear me well? Please type yes if you can. Okay. Okay, perfect. Okay, so my last topic for today is about the use of technology in chronic care. So after this topic, you will have a break. Then my colleague will come and give you three additional lectures for today. So we have a total of six lectures today. This is my last lecture, but you still have three after the break. So use of technology in chronic care. We already talked this in the first topic about hypertension and diabetes, which are chronic diseases. Then we talked about the quality of life in patients with chronic diseases. And now we'll talk about the use of technology in chronic care to see if there is a role or a role of technology in these conditions. So I will start by talking about remote patient monitoring, known as RPM. So remote patient monitoring, it refers to the use of technology to collect patient data outside of traditional healthcare settings. So the patient is at home, he is connected to some devices, and these devices will record important health parameters, for example, vital signs like hypertension, like blood pressure, like heart rate, like glucose level. So these devices are connected to a platform that the doctor can see in order to see how the patient is progressing and in order to change the therapy based on that. So this will facilitate virtual communication between patients and healthcare providers. So remote patient monitoring, it empowers a patient by providing them with tools, as we said, and devices that allows for self-monitoring and active participation in their health care. Patients will be more motivated when they have devices and when technology is implicated in their disease, so they become more motivated um, in order to and be more compliant with the therapy because they are seeing the results with their eyes. So the shift towards remote monitoring also transforms the traditional model of care delivery, so making it more patient-centric and adaptable to the needs of modern digitally connected world. So healthcare also should use technology because every other aspect or profession, they are using technology more and more, artificial intelligence, machines, devices. So healthcare also should implement all of these technological advances. Remote patient monitoring, it utilizes a variety of monitoring devices, like we said, wearable sensors, like smartwatches, and medical-grade devices. These devices will help collect real-time data on vital signs, especially the smartwatches. It will collect heart rate, also activity level, so how many steps the patient is doing per day, is he exercising or not. Some devices also can give you an idea about the quality of sleep of the patient. So we can use it to know if the patient is sleeping well or not. And also other relevant health metrics. Some devices can measure the glucose level, for example, or the temperature. So all of these devices, the thermometer, the pulse oximeter, the weight scale, the blood pressure, the glucose meter, the peak flow, physical, like, all of these devices, the data from these devices can be connected to a platform. And this platform, the information will be stored inside and is connected to the healthcare platform that the doctor can see. He can see all the details and all the numbers on this platform. So very useful. One of the most common disease that can be detected by these devices is atrial fibrillation. Atrial fibrillation is a chronic disease. So what happened in atrial fibrillation? As you know, the atria in the heart, usually it should contract regularly. So each interval of seconds, milliseconds, the atria should contract once. But in case of atrial fibrillation, the atria will contract in an irregular contraction. So there will be loss of regularity. So the heart rate will be irregular. And if you can see here on the ECG tracing, so the first one, the sinus rhythm, sorry, the sinus rhythm, you can see that the heart rate is regular, while in case of atrial fibrillation, you can see that the interval between two complexes is not the same. So this is irregular heart rhythm and atrial fibrillation, and these devices can diagnose this condition because it's a very frequent condition, and most of the time it's undiagnosed. It's undiagnosed when it happened with a complication. The patient will present with complication like stroke or other complication, but we should try to detect it earlier on because it's also a very frequent atrial fibrillation disease. It's a chronic disease and it's associated with a lot of comorbidities, especially heart disease and stroke. Because when the heart is contracting in an irregular form, there is a risk of the blood will stagnate in the atrium of the heart. And there is when the blood stagnates or the blood will not circulate properly, there is a risk of clot formation. And if the clots will form in the atria, there is a high risk that it will migrate to the brain by going to the left ventricle, then going to the aorta, and from the aorta it can go to the brain vessels and cause a stroke. So this is why we should detect it because we can reverse it and we can give anticoagulant medication in order to prevent the clot from forming and to prevent the stroke from forming. This is a case, I will show you a case of a 58-year-old female. This female has a wearable device, so she has a smartwatch. And the watch recorded this tracing. So it recorded. If you can see the tracing well, it's not very clear maybe, but you can see that the heart rate is irregular here. So the interval between each beat to beat is not the same. So this is atrial fibrillation in this case. And they showed this tracing to doctors in the studies, and 83% of doctors said that yes, they can diagnose atrial fibrillation just by looking on this wearable rhythm without the need to do further tests. And 72% of these doctors said that they can start medications to treat it, so anticoagulation, just by looking on this tracing. So it's very important. If this patient doesn't have this wearable device, she was an asymptomatic patient, so she didn't feel that she had irregular beats. And we found out from this wearable device that she's having episodes of atrial fibrillation. So if this patient, if left untreated, she's at risk of developing a lot of complications, including stroke, which is a complication that can lead to mortality. So this device helped 83% of doctors to diagnose this issue and 72% of doctors to start the medication just by looking at this without the need to do other tests like do an ECG or an echo or a Holter to record the heart rate over days. So it was sufficient to most of them. How does these new watches work? So you can see that the patient need to place his thumb on a sensor. Some watches record without placing the thumb, but some of them you need to place the thumb on a sensor. And this sensor, the application will utilize an algorithm to differentiate regular beats, so sinus rhythm, from atrial fibrillations, which is irregular beating of the heart. And sometimes it cannot diagnose it, so it's said that it's unclassified. So we have three possibilities. Either we have a sinus rhythm, so regular heart rate, or we can have irregular heart rate, so we diagnose atrial fibrillation, or sometimes we have a lot of artifacts or it's not clear, so the system will say that it's unclassified. And the app will inform the patient if atrial fibrillation is detected, and the results are directly transmitted to the physician. So in real time, the physician can detect atrial fibrillation in real time in order to start the treatment in a fast way. And you can see that the app has a 93% sensitivity to accurately diagnose atrial fibrillation and 84% specificity. So these numbers are really good with just putting a wearable device at home to diagnose a chronic disease. These numbers are really good. So you can see here we have different manufacturers. We're not talk about we're not doing a commercial we're not talking about them commercially, but just to let you know that there exist a lot of types. Some of them, most of them detect AFib, atrial fibrillation in 85%, so sensitivity of 85, and the specificity range between 60 to 75%. They can interpret heart rate when it's between 50 to 150 or 50 to 120. Sometimes when the heart rate is very fast, it become so the machine will not be able to interpret it. So ideally, it should be between 50 to 120 or 50 to 150. And each device has a different battery capacity. So these are details that we're not going to go through. We just need to know that most of them, they should have a heart rate between 50 to 120 in order to detect the arrhythmia. What changed? Why we're now using all these devices and we're using telemedicine and remote patient monitoring? Before coronavirus, before COVID, there was only 20% relying on telemedicine, so like video consultations or remote patient monitoring. While during the COVID pandemic, so between 2 to 3 years, we saw a very big rise in telemedicine up to 60% of cases. So approximately 60% of cases were treated virtually. And after the coronavirus pandemic, it's dropping a bit, but it's above what it used to be before the COVID era. So maybe it's a trend. We'll see in a few years how this will evolve. But I think with the use of technology, it will keep on, it will stay like this, or maybe it will increase furthermore. So how of all of this works? So when all these devices detect the information, these information are stored uh, in a cloud-based system, and all of this is transmitted and analyzed by appropriate healthcare workers, and the doctor will receive also the information, and he will be able to know what exactly is going on. He will be able to diagnose chronic diseases and change the therapy. It also has an alert mechanism. So remote patient monitoring system, they incorporate alert mechanism to notify healthcare provider of critical change. For example, let's say a patient has a heart rate of 180. Uh, this will activate an alarm in the healthcare provider in the hospital. They will call the patient and will tell him to come to the emergency room. And this will so the patient will have more rapid intervention and more rapid management of a potentially life-threatening issue. So this is very important mainly for arrhythmia or for hyperglycemia or for hypoglycemia. If we're able to monitor these and have an alert or alarm system that notifies the hospital, it will decrease mortality significantly. It's also used to early detection, as we said, like atrial fibrillation. We can detect it earlier because most of the cases they are asymptomatic. Same applies for hypertension because, as you know, hypertension is known as a silent disease. Most patients with hypertension they don't know that they have hypertension. So early screening with these devices will help us detect arrhythmias, detect high blood pressure, detect diabetes, because all of these are silent diseases at first, and they tend to show and to cause symptoms at a later stage, at the stage of complications. So continuous monitoring provides a more comprehensive understanding of patient health, enabling personalized care plans. As we said, uh, it also breaks down geographic barriers. So let's say a patient lives in a very far area that doesn't contain big hospitals or doesn't contain, for example, different specialties. So in that case, we can use telemedicine and remote patient monitoring. So all patients will receive care regardless of their location. And it's also particularly beneficial, as we said, to underserved areas like mountains or rural areas, improving access to specialized medical expertise. So he doesn't need to see a doctor in his area. Maybe there is no specialist like ophthalmologist or subspecialist. So in that case, he can seek advice from a different country or a different area. Patient will be more engaged because we said that when the patients are seeing all of these data, they can participate in the healthcare journey They can self-monitor themselves. They know when something is wrong, when something is right. Um, so they are more likely to adhere to treatment plans and lifestyle modification in that case. It's also cost savings because let's imagine, for example, when we do this, if we can do some video consultation for not urgent situations, in that case, for example, we can decrease the emergency interventions. For example, if something doesn't need emergency room service, we can do it by remote patient monitoring or telemedicine. So this will decrease the costs. And it will also when we detect disease earlier and start treatment earlier, we'll avoid complications. So also we will decrease the cost of the intervention that we need to do more. So it's very cost effective. Maybe in the beginning it will be costly to implement it in the system. The machines, the technology will cost a lot in the beginning, but the studies showed that on long term it's associated with decrease in the costs on long term. So patients will be more satisfied because they can actively participate in their care and experience and personalized attention. So as we said, also it can be used to monitor vital signs, but also for post-operative patients. So patients that has undergone surgery, we can try to discharge them earlier on, and we can keep monitoring them when they are at home, monitoring their vital signs, their pain level, and you don't need to keep the patient for in hospital for long term. We need to try to do an early discharge at home, and this is the trend now to do early discharge after any procedure and keep monitoring the patient at home. So the recovery experience will be enhanced for patient, and this will facilitate the detection of complication after the surgery. We said this many times, so early detection, we're focusing on early detection, like we said in atrial fibrillation, so we can start the treatment early, and so this will be cost effective on the long term. I will talk now about remote patient monitoring in specific disease conditions. So I will firstly talk about the case of heart failure. So in case of heart failure, for example, congestive heart failure, there's different types of heart failure. There is a type of heart failure when the muscle of the heart is not contracting well. We call this heart failure with reduced ejection fraction. So we can measure the ejection fraction by doing the echocardiogram. And when it's less than 35%, so the muscle is, I simplify it, so it's working like 35% of what it should work. In that case, we call it heart failure with reduced ejection fraction. We have another type of heart failure when we have a normal ejection fraction, so the muscle is contracting well, but the heart is not relaxing like it should. So we have a diastolic heart failure. So in both cases, the patient will be having symptoms of dyspnea, a shortness of breath due to volume overload and fluid accumulating in the lung because the heart is unable to pump the blood. So all the blood will accumulate in his lungs. It will accumulate in the lower limbs, in the venous system. So the patient will have swollen legs. He will have bloated stomach because also fluid will accumulate in his abdomen. This will cause ascites, and also the fluid will accumulate in the lungs. So the patient will be short of breath, will be fatigued. Have fatigue, will have swollen lower limbs. So in heart failure, remote patient monitoring is very important. And if you look at the guidelines, it's a class 2B indication. So class 2B means that we can do it, but it's not very, very recommended, but it can cause some benefit for the patient. So they suggested, for example, to use a device and place it in the pulmonary artery in order to keep monitoring the pulmonary artery pressure. Because as you know, pulmonary artery pressure when the patient is in heart failure and in fluid overload, the pulmonary artery pressure will go up. So it's like a monitor of the fluid status or the fluid balance in the patient if he's in fluid overload or if he's dehydrated. And if you look on this curve here, you can see this is a pulmonary artery tracing. So what really is important to us is the systolic pulmonary artery pressure. In this patient, for example, this is a real patient. You can see that this patient has a systolic artery pressure of around 80 millimeter mercury, which is high. So this patient is in fluid overload. But how can we change the management by looking on this graph, for example. If you look on the graph, on the lower graph here, I will try to use a pointer. So if you look here on this graph, you can see here there is a spike. So there is an increase in systolic pulmonary artery pressure. So when there is increase in pulmonary artery pressure, we know that the volume is increasing also. So in that case, we can tell the patient to increase his diuretic. So increase his torsemide or his furosemide or Lasix, as you know it in the hospital. So when we see a spike in the pulmonary artery pressure, in that case, we suggest the patient to increase his diuretic or double the dose or increase the dose in order to decrease the fluid overload. As you can see here, after taking the medication, the furosemide, the diuretic, the pulmonary artery pressure dropped. Then it came back up again, and here we also increased the dose. So you can see here are different days. So this is another day, here is another day. It drops in between. So we can adjust the medication based on this device. For sure, it's not very available, this device. Not it's very hard to get. It's cost a lot, but it can have some benefits, especially in patients that are resistant to treatment and that patients that are chronically in volume overload. We don't know how to adjust the dosages, so it can help us a lot. Another condition, a chronic condition, which is sleep apnea. So sleep apnea is a disease that occurs during sleep. So patient will have obstruction of their airways or blocked airways when they sleep. They tend to have snoring and decrease in oxygen saturation at night. It's a chronic disease as well. It will cause depression, diabetes, heart failure, hypertension, and decrease in concentration because the patient will have quality or decreased quality of sleep. So he will wake up a lot at night due to the apnea episode that he's having. So during the day, he will feel sleeping, he will feel drop of concentration and memory problems. It's a very common disease and it's most of the time left undiagnosed. Usually, it's a result of anatomical issues and doesn't go on its own. So, in that case, for example, we can have allergies. We can request jaw surgery to modify the anatomy because sometimes we have a disease called retrognathia. So the jaw is is um, is further on the back, so it will obstruct the airways especially when the patient is in a supine position or on his back, the airways will be blocked at night. We can also suggest weight loss because when we decrease the weight, we decrease the fat around the neck, and this will liberate the airways even more. When these things doesn't work, we have to put the CPAP, the continuous positive airway pressure machine. This CPAP will provide pressure at end expiration, so it will keep it will keep the airway patent mainly at end expiration, so it will prevent the airway collapse at night, and is very effective. How the doctor can be connected to this machine, for example, the CPAP can register information. This information can be stored in a cloud or in a mobile application, and all of this data can be transmitted to the professionals or to the doctor in order to see if the patient is really compliant with what we're doing. So here is an example, a real example of a patient. You can see here the machine is recording everything, and these information are transmitted to the doctors. It gives us an idea of how much hours the patient is using the CPAP. So here, for example, this patient is using the CPAP at night for more to 4 hours in 12 days. But in 2 days, he used it less than 4 hours. So maybe he was less compliant in these 2 days, or he didn't sleep. He didn't sleep well. It gives us also an idea on the average hours per day. So this patient used it for an average of 5 hours, 41 minutes each night. It can give us also an idea if there is a leak. So this patient have a 7.2 liter per minute leak. It gives us an idea of how many apnea events the patient is having, so the apnea index. It's a very important tool to analyze the situation of our patient. So remote patient monitoring is very important. Another slide for the same patient. So here also it give us um, tell us of how many hours the patient is using it. So he used it for 8 hours, for example. It give us an idea if the patient is compliant or not. So when you see the green graph here, it means the patient was compliant. But for example, on Saturday, the patient was not compliant with the use of the CPAP. Same here for another patient. It gives us an idea of the usage, how many hours he used it. For example, this day the patient did not use it. If there is leak, because when there is leak, we can try to fix. Sometimes the mask is big. So for the patient, so the air is leaking from below the mask. So in that case, we know that we need to use a smaller mask for the patient. We can check the pressures that we are putting, if the machine is giving the adequate pressure to keep the airway patent. And the most important thing is to know how many apnea-hypopnea index the patient is having, so how many apnea episodes the patient is having in night. So we can monitor all of these parameters just by looking on the data that the machine is giving us. So we talked about heart failure and sleep apnea. Now we'll talk about the third disease and how can we use remote patient monitoring in this disease. We'll focus on chronic kidney disease, which is very frequent disease and increasing in incidence each year. So you can see here we have a healthy kidney. We can see the microscopic view of the kidney. You have the glomerulus, which filters the urine and the blood. You have the collecting tubes. And what happened in case of a damaged or chronic kidney disease patient? You can see that the glomeruli are now damaged and we have fibrosis or scar tissue replacing normal tissues. So we have a lot of fibrosis going on. That's what happened in chronic kidney disease. That's the main issue, is that we have replacement of normal tissue by fibrosis or scar tissues. So the kidney is dying. And when we have a lot of fibrosis, it will cause a tension inside of the cells. And this will cause shrinkage of the kidney, and the kidney will become smaller. If you look on imaging of all chronic kidney disease patients, you will see that the kidney has decreased in size, and this is due to development of fibrosis and tension inside the cells. So a typical kidney has about 1 million filtering units, uh, and each unit is called a glomerulus, and it joins a tubule to filter the blood. Then the tubule, when you filter the blood, you will have the urine. Uh, it will collect urines. It will collect the urine. And in conditions such as high blood pressure or diabetes, so this kidney will have fibrosis replacing the normal tissue, so you have scar tissue. And the most common cause of chronic kidney disease is blood pressure and diabetes. So the kidneys will be damaged. The patient will have dry and itchy skin as a result, tiredness, weakness. They will have foamy urine. They will have swelling. They will have swelling because when you have a chronic kidney disease, the kidney will be unable to reabsorb proteins. So will lose protein in the urine from the blood. When you lose protein in the urine, you will have a decrease in oncotic pressure. So oncotic pressure is the pressure inside the vessels that keep the fluid inside the vessel. And when you lose proteins, so you will have low oncotic pressures. So you will have a fluid that will go from the intravascular space to the extravascular space. So that's why you have swelling in case of kidneys. So the lower limbs will be swollen in this case, like the case of heart failure. You will have puffy eyes, also trouble sleeping, loss of appetite, muscle cramps, and they need to urinate more in early stages. So all of these symptoms can decrease the quality of life in these patients. And here is a classification also of chronic kidney disease because you need a specific therapy for each stage. It's not the same for everyone. So you always measure the creatinine and with the creatinine and you can conclude what is the glomerular filtration rate of the patient, so the GFR. When it's above 90, in that case, there's normal kidneys or mild kidney damage. So kidneys are working normally here. But as the GFR drops, so when the GFR drops, it means the kidneys are not functioning well. And when we reach a GFR of less than 15, so here is a stage 5 or end stage. In that case, we have the most severe kidney damage. Our kidneys are very close to not working or have stopped working. So we have kidney failure here. And most of these patients will require dialysis in order to treat the chronic kidney disease or renal transplantation. So you see here as an example of a dialysis patient. So we have catheters connecting the patient. So we have arterial catheter and a venous catheter. You can have different sort of catheters. You have a dialyzer, and which will be used to filter the blood from the toxins, and the blood will be given back to the patient, which is filtered from the toxin. So he will receive clean blood. How can we use remote patient monitoring in patient with chronic kidney disease and undergoing dialysis? And is there any benefit of using remote patient monitoring? This study will answer us. It was published in 2023. It's a recent study. You can see the dotted black curve here on the graph. This is for patients with CKD and dialysis that did not receive remote patient monitoring, while the red curve here is for patients that received remote patient monitoring, and they checked mortality in both groups. You can see that mortality in patients that did not receive remote patient monitoring is higher. So it's around 10% compared to around 2 to 3% in patients that received remote patient monitoring. And why is this? How can we explain it? Because patients, for example, that are on dialysis or chronic kidney disease are at risk of developing heart disease and arrhythmias, and they can die most commonly from heart issues. So when we do remote patient monitoring during dialysis sessions, we can detect these things and prevent them. So it was shown that it decreased mortality, and it was significant decrease in mortality because it has a p-value of 0.022, so this is statistically significant decrease in mortality. So, okay, so we talked about three diseases till now: heart failure, sleep apnea, and CKD, and we still have to talk about the use of remote patient monitoring and technology in cases of diabetes. So we'll pass on this briefly because we already discussed about diabetes in the first session. We said that we have three types. We have the type 1 diabetes, which is usually autoimmune. In this case, the antibodies will attack the beta cells of the pancreas, so the beta cells will not produce insulin at all. So this patient will require insulin lifelong in order to survive. And the type 2 diabetes, we said it's usually occurs in older age, but now we're seeing it more commonly in younger age due to obesity and diet. It's due to insulin resistance and will lead to elevated blood sugar level. And most of these patients will suffer from other conditions like heart issues, hypertension, chronic kidney disease also. It can be prevented by diet and a healthy lifestyle. The third type, we said we have this gestational diabetes, which occurs only in pregnancy. It's due to a genetic or environmental risk factor, and the blood sugar will return to normal after delivery. We said also we use the hemoglobin A1C to diagnose it. So when it's less than 5.7, it's normal. When it's between 5 to 6.4, it's a condition of pre-diabetes. And when it's above 6.5, it's established diabetes. We also said that we can use fasting blood sugar to detect it. So normally it should be less than 100. Pre-diabetes should be between 100 and 125, and diabetes is above 126 milligram per deciliter or higher. So we need to act here on pre-diabetes, as we said, in order to prevent that the condition moves to diabetes. So this study is about the usage of remote patient monitoring in diabetes patients. So most of these patients will record their glucose level at home, and the glucose level will be transmitted to the doctor in order to modify the insulin dose or other medication dose. And you can see that these patients said that remote monitoring was helpful. In 65% of them, they said they were helpful and they were happy about this technology. 35% said that they saved time by doing this. And also they said that the most common type of transmissions information is by text messaging with the doctor. And most of the change in therapy was to change the insulin dose. So it's very easy. You just send a message to the nurse or doctor or the healthcare professional taking care of this, and this professional will tell the patient which dose of insulin to take before meals or the long-acting insulin that we take once a day. So it's very important, especially to change the insulin dose and to prevent hypoglycemia, because sometimes the patient will take abnormal doses of insulin, not based on the glycemic glucose level. So it will tend to cause more hypoglycemia if the dose is if the dose is inappropriate. So we said the remote patient monitoring. We just have a few more slides about telehealth. So telehealth is also known as telemedicine. It's the remote delivery of healthcare service and medical information using electronic communication technology. So here we can do video consultation, not just transmit the data to the doctor. We can do the consultation virtually online. The first time this was done was in year 1965. It was a Dr. Michael DeBakey. He's a US doctor. He recorded all of his surgery, the open heart surgery, and the doctors in Geneva and Switzerland, they were able to see the surgery live, and he teaches them how to perform this complex type of surgery. So this was the first evidence of telemedicine, is to transmit the um, surgery skills to different healthcare workers. So it breaks down geographic barriers. We said that patient can consult with physicians that lives in a different place. It's beneficial, especially in rural areas or underserved areas where there is no big hospitals and when we don't find all the specialties. So anywhere, anytime, and it's for everyone. So everyone can benefit from it depending on the geographic area. Here is an example of what happened during a hurricane, for example, because as you know, during hurricane, patients will not be able to go to the hospital. So this was an example of hurricane which was named Florence in the United States. So in this study, they included 33 patients that were not able to go to the hospital, to the emergency room. So an average cost per patient is $1,200 for each emergency room visit. Also for transportation, to transport the patient to the hospital, it will cost the ambulance around $415 for the nurses, the doctors, the cost of transportation. So if you combine all of these numbers together for the 33 patients, you can see that telehealth has saved $53,295. So it was beneficial for the economy, as they were able to document this during a hurricane, because during a hurricane or a pandemic, we will see increase in telehealth consultations. Also, the wait time will decrease a lot when we do telehealth, because on average, uh, 20, after 20 minutes, patients think their time is being wasted. So in this study, they asked a lot of patients about how much do you wait in doctors, and most of them said that after 20 minutes, they will find that they are losing their times. And in this study, they said that these patients, in around more than 25% of cases, they waited more than 20 minutes. And it's very rare that they don't wait. So most of the time, patient will have to wait a long time before seeing the doctor. And also in the emergency room too, some emergency room are always full of patients, so there's a lot of waiting time, maybe sometimes more than 1 hour waiting time just for the first contact with the doctor. So here in 25.4% of cases in this study, the patient has to wait more than 1 hour to see the doctor. And sometimes it's for just a benign condition that doesn't need an emergency visit, but the patient doesn't know and he will go to the ER every time. So in this case, maybe telehealth or telemedicine can be implemented. Also, physician, when they have a lot of wait time, they say that um, around 28% there is a moderate impact on patients. So the patient will not return to see the doctor again. They will be less compliant, which is a very difficult condition for the patient and for the doctor too, because the same study too, they said that 23% of patients have left the office without ever seeing the doctor because of the wait time, and 22% of patients have told friends and family not to make appointment with that doctor, and 19% of patients have changed doctors specifically to avoid original doctor wait times. So you see that it has impact, the wait time, it has impact on patient satisfaction and also on the economy. The most common device used for doing telemedicine is the telephone. Also, we can use Zoom or other applications that are specifically used for doing medical consultation online. It's most commonly used to follow up. For example, as a patient comes to see us in the clinic, we ask for to do labs. The patient does not have to come back to us in the clinic just to see his labs. We can organize a video consultation with the patient uh, just to see if his labs are working fine, if we need to change some medication. It doesn't have to be a visit to the clinic. We can replace this by doing, for example, a video consultation just to discuss the lab results or the tests that we ask the patient to do. What aspect of technology can we use also to in medicine? We have the 3D printing. So the 3D printing is used to relate patient-specific medical implants, so prosthetics implant or even human tissue. It's very customizable depending on each patient. It will reduce the cost and it will improve the patient outcome. So you see, this patient was amputated, has an arm amputation due to a car accident, and she received a device which is a 3D printing medical device in order for her to regain a bit of her function. It also can be used for patients that are amputated in the lower limbs. These patients can be diabetic or have an accident or any type of cause. You can use these devices for these patients. So technology is very useful here too. For digits also, we can use a device for that. So these devices are very cheap. They are not doesn't cost a lot. They are manufactured very quickly. So 3D printing is very fast. They are resistant and durable, and they are customizable based on each patient need. The challenge here is in technology overall, we need to ensure patients understand how to use telehealth tools effectively and be comfortable with this technology. We need to explain the patient how to use the device. It's very important, otherwise the patient will not use it. We should also provide user-friendly devices. We need to train them and having support if the patient doesn't know how to use it, we need to support him. So telehealth is projected to expand further year after year. It will cover a wide range of medical specialties and services. It will cause a decrease in healthcare cost on long term. We said we will decrease the emergency room visit, will decrease the wait time in the clinics, will decrease the wait time in the emergencies too. It will also improve patient outcomes. And now you'll all hear about artificial intelligence and machine learning. So we have a lot of tools that will help early diagnosis. We now have tools that are developed to diagnose cancer early, to diagnose other health issues early, to have signs of that this patient can have cancer in the future. So all of these genetic AI tools that are being used and are personalized for each disease and each patient. This will lead to faster and more accurate diagnosis, accurate management, and improved in patient outcomes. So that was my presentation about technology in healthcare. If you have any other questions, if you have questions about this topic or any question about the previous topics, please ask them now. Any questions? نو ما راح الصوت بس خلصنا هيدي الليكتشر. إذا عندكم questions أو any other question فيكم تسألوني هون بالchat. We have few minutes for questions. You're welcome. So we finished خلصنا the first part. I gave you 3 lectures. My colleague will give you 3 additional lectures, but you have a break now. I think you have a 1 hour break, I think. You still have around 3 hours, Jumana. Okay, so I have a question from Ahmed. He's asking about what about the medical legal aspects of telemedicine. Yes, I agree with you. It's not very well standardized now, especially depending on the specialty too. Some cases you can't just do telemedicine. You need to see the patient physically because you need to do physical exam and examine the patient well. But in other cases, like for example, if you need to follow up with the patient and just see his labs or follow up on a condition or a test that you ask, I think in that case you can use telemedicine easily. But I agree with you, it's still the legal aspect because it's still new. We don't have standardized approach to this issue, but I think it will come within the years. Yeah, mm, that's it. You're welcome. Okay, any other question? حد عنده سؤال بعد أو بده يسأل عن شيء حتى عن the previous lectures you can ask me about the first 2 topics. Okay, great. So now you will have a break, I think, and then you will have 3 remaining lectures.
Can you hear me? هل الصوت واضح؟ تقدروا تسمعوني بشكل كويس؟ Okay, great. We will continue. There is no break now. Inshallah, at around 7 or 6:45, we will give you Salah time and like little break. Then we will continue. فإذا حنكمفي بدل ما يكون وقت البريك ساعة هيك بنختصر منه ونخلص على بكير إن شاء الله أبكر. Great. It's okay. Okay. طيب. Let's start. فإذا good evening everyone and welcome to our webinar. First of all, thank you for the organizing committee who organized this excellent webinar. Thank you for Dr. Antoine. Thank you for the اللجنة العلمية واللجنة الفنية. And thank you for for giving us the opportunity to be with you during this very fruitful day. And we will be talking about one of the very important section, which is the experience of patient with the critical illness. As you know, and as discussed with the previous sessions, that the type of critical illness شو هي critical illness, diabetes, hypertension, how it will end, what will be the complication, and as you know, for the long-term complication, it won't happen suddenly. For example, let's say you have a patient who has a diabetes patient. It will take a year sometimes just to end with renal failure and to be hemodialysis. Okay, as usually we have 2 type of complication. That some of the complication that it might happen during a short period of time, and it required a lifestyle, and usually complication, the long-term complication, it will come after years, but it doesn't mean that it will happen 100%. يعني at some point, if you will take the diabetes case and the treatment by insulin, it's not going to treat the patient. For example, you are not going to be out of diabetes. You're not يعني by taking the insulin وقت بناخد الانسولين نحن مش عم نشفي السكر. It will manage your case وبتمنع من خلال ما نركز السكر بنمنع انه يصير في عندنا long term complication اللي رح نشوفها خلال السيشن الثاني. Okay, فاذا this is very important that some of the patient or some of the disease that patient will have an experience. It might be a good experience that he will go through the disease, long-term disease, and he will end with complication. And we witness already a lot of patients, كمان نحن بنشوف كثير من الحالات, we witness already a lot of patients that they had the diabetes or hypertension after a years and there is no complication. Why? Because there is a lifestyle, good lifestyle, good medication treatment, exercising, quality of food, follow up with doctor. فإذا في كثير من العوامل it will give us a good experience with the long term disease. Okay, and فإذا كله بيعتمد على المانجمنت and how we manage and how we did a follow up. فإذا كمان كثير مهم نعرف إنه some of the patient they will end in a critical complication. Like what? يعني إذا أنتم مريض مثلا you have diabetes or hypertension. إيش هي ال complication that you might end in to being a patient in the ICU? Like what? Give me example. يعني شو هي بعض ال complication اللي ممكن تصير معكم if you did not manage your case, you will end with to be in ICU. Like what? ممكن تعطيني مشاركات أو example؟ زي إيش مثلا؟ You have a chronic disease case وأنتم ما انعمل له management and هون عم نحكي عن what is your experience with this one and you might end in ICU. Give me example that some of the chronic disease اللي hyperglycemia. Thank you. Coma. Like what type of coma يا أخ هيثم؟ Stroke. Excellent. Stroke. Diabetes foot, which is long term. Diabetes ketoacidosis. Thank you. ممتازين. فإذا how they are complication you will end being a patient in the ICU. إذا هيدي سواء صار في عندك stroke أو صار في عندك hypertension crisis أو صار في عندك diabetes foot أو diabetes ketoacidosis أو severe hyperglycemia or coma acidosis and whatever. هيدي كلها complication you will end being a patient in the ICU. طيب. Now we will be going straight to the one of the objective which is pneumonia. Excellent. Why pneumonia? يعني اللي حدا من الأخوات هنا قالت لنا نمونيا. ليش حسب رأيك بصير نمونيا؟ أخت أحلام. Why do you think the patient he might end with pneumonia إذا كان عنده مثلا one of the complication? Shortness of breathing. This is يعني one of the but why خلينا نركز على موضوع النمونيا for example. بما إنه الأخت أحلام she mentioned pneumonia لأنه بتعرفوا this chronic disease it will make the patient immunocompromised ضعف بجهاز المناعة وبصير معرض يلقط أي نوع من البكتيريا أو الفيروس وبتكتر هذه الأشياء خلال فترة الشتاء والإكسبوجر للبيشنت غير مرضى. مشان هيك it's a good answer that بنشوف كثير من مرضى they end with pneumonia or severe pneumonia. And if you will go back during the COVID بنشوف يعني معظم المرضى اللي كانوا they end بالاي سي يوز intubated والى اخره هن they end with severe pneumonia. هن مرضى معظمهم اذا بترجع للجو باك للهيستوري هن مرضى عندهم chronic disease يعني مرضى الديابيتس ومرضى الهايبرتنشن هن اكثر مرضى هن اكثر نوعيه من المرضى كانوا معرضين للكومبليكيشن severe complication of COVID. يعني وقت كنا ناخد 10 مرضى dialysis patient hypertension و10 مرضى they are young with no disease وبنشوف how it end the story سواء من negative for example يعني pass away intubated بتشوفوا انه 90% من المرضى اللي كانوا intubated they end with لانه عندهم diabetes وعن chronic disease والمرضى اللي they pick up هن young people ما كان عندهم immunocompromised problem بيناتهم diabetes والhypertension. جريت. فاذا يا اخت نورا الحين بدينا يعني الدوره مثل ما تكلمنا نحن وي هاف في عنا جدول معتمد من الهيئه، نحن ما فينا يعني نزيد على السيشن نشيل منها. شغله نحن كنا اللي فينا بنعطيكم ساعه بريك، ممكن نشيل من وقت البريك بدل 3 ساعه نعطيكم اياه ربع ساعه، هيك 3/4 ساعه بتخلصوا ابكر. بقى نحن الوقت بالنسبه لنا ثابت، ما نقدر نخلص قبل الوقت. انا بعرف انه ايفنينج وجايين من دوامات ونحن كمان والكل، بس بليز ذس از فيري امبورتنت لانه الكل عم يسال متى تنتهي الدوره. يعني ان شاء الله بدنا في برنامج بده يخلص ان شاء الله خلال ساعتين من الحين بنكون مخلصين، اوكي؟ بس ما فينا نخلص قبل الوقت، ونحن قصد يعني انا بعرف الايفنينج بيكون شوي تشالنجينج، بدل ما يكون بريك ساعه حنعطيكم بريك ربع ساعه منشان اقدر استعمله بالسيشن. بقى لو تكرمتم شوية وقت وإن شاء الله بيكون كل شيء بخير. أوكي، الله يعطيك العافية، شكرا لك. طيب إذا here this is فإذا مثل ما حكينا هودي المرضى they will end with the ICU. Now what will be the experience for example. Don't worry dear Mandy, it will be يعني I need to speak in English and Arabic as well. Just I know some of the participants they are not well in English or in Arabic. And I will try to be in between. I will talk in English and translate in Arabic and vice versa. Okay. Now let's see that we are focusing on the experience of the patient for a long-term disease. And I'm going to ask you example. For example, you have a patient who is early diabetes patient and he managed his case and he's okay. After years, start on complication and the complication was managed by the doctor. يعني صار في عنده تفاعلات السكر وبعض الcomplication but never he end in the ICU. Now, this patient suddenly he has a severe pneumonia, for example, or severe infection, and he was ending in ICU. What will be, do you think, the experience of this patient in the ICU? What will be the negative experience and what will be if there is a positive experience, do you think? فإذا give me example. What is your thought? كيف تعتقدوا إنه مريض he has immunocompromised and he end in the ICU? ايش هي الاشياء اللي ممكن تخوف؟ ايش هي الاشياء اللي ممكن يخاف منها؟ ايش what will be the experience? And did you have the experience before? Share me your thought. شو بتعتقدوا بهذا الموضوع؟ Delirium. Why? Which kind of patient أخت عهود will end with delirium؟ يعني I agree with you but okay, let's discuss one by one. Delirium. Delirium usually it will come for the patient in the ICU who have been intubated for 2 weeks or 3 weeks and above, okay, who have been intubated 2 or 3 years, then extubated. This patient, they will face a delirium بيصير في عندهم نوع بنسميه ICU delirium. ليه؟ لأنه they are sedated for a long term. بيكونوا sedated على وقت طويل وبعدين they will extubate after 3 weeks. طبعا بيكونوا sedated رح يكونوا بالICU مش غير مطرح. After 3 weeks, they will wake up. Will show, for example, they have problem on recognizing people, recognizing the date, the time, the what's going on, where they are. But later on, they will be fine. فإذا مثل ما تفضلت يا أخت عهود, I agree with you. Delirium, بس مش يعني if in case they have been intubated for a long time, يعني it will not come for a patient who has any patient in ICU. لا, patient اللي بيكون already intubated for a long period of time 2-3 weeks وبعدين extubated and بيصير في عنده يعني this complication. Thank you, excellent point. طيب بقينا الأخ هيثم شريف which is a lot of alarm. Excellent, this is another point to discuss. اللي بيكون بالاي سي يو كمان as you know ICU it's a highly critical areas and it required a close observation. من الاي سي يوز هي منطقه تحتاج مراقبه حسيسه ومراقبه دقيقه، والمرضى اللي بيكون جاي على الاي سي يو اول شيء سواء حالته يعني one of the complication which is long complication مريض يعني this is the first time، هذا موضوع الالارمينج بيسبب له الكثير من الخوف والكثير من القلق، يعني he won't be able to sleep يعني ما يقدر fear of death excellent يعني بيحس هالمرض دائما بالاي سي يو، يعني احنا بنعرف كلنا ستاف سواء بالاي سي يو او بغير الاي سي يو، وبنعرف انه المرضى هن الهايلي كريتيكال. في كثير المرضى اللي بيكونوا conscious اورينتد بيشوفوا كثير من المرضى انه فجأة they had a code بيجوا ستاف try to intubate وفجأة patient did not pick up he will end with death، وهذا الشيء بيسبب كثير من الخوف. يعني انا I witnessed one case my father-in-law he's a long-term diabetes patient and he had a severe pneumonia تمام، واضطر يفوتوه على الاي سي يو بسبب السيفير نيموزا. he is young وخلال الليل اللي امضاها بالاي سي يو he was crying he was shouting he did not tolerate one night in ICU. why? because after 12 o'clock the near patient المرضي اللي حده he had a cardiac arrest و they tried to resuscitate him he did not pick up he death in front of him، فإذا توفي بوجهه توفي بدغري and he had a very poor experience. يعني أنا I'm sharing you this is a very great example. والحين كل ما أشوفه بيقول لك أنا أفضل الموت وما بروح على الاي سي يو. he is my father in law يقول لك أنا الحين بفضل شو ما كان يكون ولا بفضل روح على ولا نام ليلي بالعناية المركزة. this is a great example and this is فإذا هذا الشخص هو immunocompromised هو عنده complication تبع الديابيتس he end مع renal failure وعم يعمل session of hemodialysis واضطر يفوت على الاي سي يو على فتره محدده، واول ليله ما قدرت اتحملها وقلت لكم انه the experience was a very poor experience. بيقول لك انا بفضل شو ما كان يكون ولا ضلني ليلي في العنايه الفائقه لانه I witness one patient or one case who pass away. اوكي طيب impairment and pain or discomfort كمان by default he's going to have a pain لأنه he's not moving he's always connecting to the alarm يعني المونيتورينج والدايناميك وكلياته، فإذا he will have فإذا هيدي إذا بنحكي على ال negative experience related to a patient immunocompromised or on chronic disease و he was admitted into ICU. طيب do you think there is any positive experience for this? لمريض who is a long-term complicated patient and he is admitted into the ICU. Do you think spiritual, what do you mean by spiritual? You know, what will be the benefit that, okay, I got your point. Do you think by facing the chronic disease ونحن ككائنات بشرية وكأشخاص we had a chronic disease وأمراض for a long term، هذا الشيء بيشعلنا نكون جدا cultural and religious ونطلب الرضا والسماح والعطف من رب العالمين. I agree with you a very valid point أخت سارة. فإذا this is a very valid point إنه نحن being in the ICU from a chronic disease مش عم لك انه suddenly لانه مريض بيكون already قطع ب long experience. يعني مريض السكر اوقات يوصل مثلا لمرحله الديابيتس فوت والدياليسيس والدياليسيس it will take maybe 15 years 20 years to have this complication. خلال هالمرحله يعني بيقطع for with a long experience. اوكي اذا هون سبحان الله وقت بفوت على الاي سي يو يعني بشوف دائما it's a area that يعني it's area that it's fear بتخوف، يعني ما حدا بيفوت على الاي سي يو غير النورمال يونت. فاذا هذا الشيء by default patient he will be have more spiritual, more praying وإلى آخره. Thank you for your feedback اختصارا. الأخ أحمد, feeling less fear in the second time for sure. يعني for the first time يعني and already I gave you example of my father. I am sure inshallah no, but in case he will go to ICU, he will have maybe better experience. لأنه دايما first time it's a very poor experience facing this big area, monitoring, doctor going and coming, a patient desaturated, arrested, comatose, fell down, everything. You will see it in the ICU. As in you will have less fearing in the second time. And one of the في أحد من الأخوان أو من الأخوات he mentioned very important point. ألا وهي أنه المريض يعني the patient he will be feeling the safety. ليش؟ وليش بالاي سي يوز we will feel more safe بينما باليونت العاديين أو بغير يونت يعني the sense of safety is less. Why? Why do you think? Okay. More quick medical response during emergency. Excellent. اليوم مشاركة ممتازة صراحة. Quick medical response during emergency. Cardiac patient had MI, underwent surgery. Okay, underwent surgery, and he ended with the ICU. Faizan, what do you think? Faizan, as you said, more response during, for example, as you said, they are rounding, okay, they are surrounded by doctors and nurses, excellent. Under safe, more physician visit, ممتازين. Emotional support. If you will be looking after a unit, for example, you see that they are a separate room and private room. And for example, doctor will come one time per day just to see the patient, okay? And for example, nurses, they will be working 1, 2, 3, or 1 to 4. One staff will look after 4 patients. At some point, and sometimes they are very busy. At some point, patient will feel that he is alone, not secure. Sometimes he's ringing the call bells, calling, but no one will come. Not because they don't want to come, because they are busy. As in the unit, the acuity is different. And this is the patient will not know, but we as a medical staff, we knows very well that the acuity بالICU بتختلف عن الاكويتي بالunit. الاكويتي بالunit, it might be sometimes 1 to 4 or 1 to 5. One staff will be looking after 4 patients, sometimes 3 to 4, and one doctor will be looking after the unit. In ICU, we don't have such acuity. We have 1 to 1 or 1 to 2. By default, each staff will see the patient in front of him every minute. This one, it will create a sense of security. Yes or no? He will feel secure that there is staff and the doctor is available. In the unit, let me give you example. Sometimes, if the patient he is desaturated or whatever, they will ring for the rapid response team to come. Okay, rapid response team will come. Okay, and it will take it will create a sense of insecurity for the patient. And I'm in ICU, in case something happen, he's in front of the doctor, in front of the monitor, and the intervention will take seconds. Abdurrahman Ghamdi, many cases in ICU for better and safe care, not yet for critical situation. Yes, excellent. And we are talking the same language, all of us. And I think it's clear to, and this is one of the experience of the patient in the critical areas compared to, which is, as we said, sometimes it's a very positive, as we said now, it look like a very positive, and in the other side it looks negative. And we give many example of positivity and many example of negativity. طيب. Now, stress already we spoke about it, that increase heart rate, and what will be the response of the patient in the ICUs. And there is many, we call it environmental stressors, يعني عوامل داخل العناية الفائقة تجعل المريض he has the the sense of negativity or sometimes of positivity. Now, what are the cause and the main fearness of the patient in the ICU, especially the patient who have a long-term cases, and they have a very long experience of anxiety, depression. They hate the hospital. They don't want to see any doctors. They don't want to face any problem. And the main complication, as we said, that it's related to trait of helplessness, loss of control. Sometimes, for example, you see a patient, he's diabetes patient, he is taking the insulin on time, he has a very excellent lifestyle, and he is doing a physical exercise, and food is excellent. He's taking his food on time, or not on time, I mean insulin on time, but he has a very good quality of food related to the case of the ICU, but or the diabetes, but still you see that the diabetes, it's not under control, because as you said, more time with the disease, the more you will have things it might be under control. And one of the main fearness and anxiety with the highly critical cases is that sometimes you will feel the losing your function and self-esteem. What type of function are we talking here؟ فإذا بنحكي إنه من أكثر الديزيز أو أكثر الكومبليكيشن اللي بتصير عند المرضى اللي عندهم very high complication like diabetes, hypertension والى اخره, they will have يصير في عندهم anxiety لانه they lose their function. What type of function? Give me idea. فمثلا عن اي function are we talking here? Excellent. Excellent. فاذا مريض kidney function يعني he will end with a dialysis. هيدي السيشن رح اتكلم عنها بسيشن ثاني، ما راح تصب علي. فاذا they will end in the patient he has a diabetes for long term, and at some point urea creatinine very high والى اخره، وصار في عنده lose of kidney function, and he end being under dialysis and in ICU under the CRRT machine. Okay, فاذا excellent. فاذا بيصير في عندي here we are losing the function of one of the main organ of our body, which is the kidney. Patient will become he will become a dialysis patient, and as you see that all the patient under dialysis they have a history or they are a diabetes patient. إذن هيدي من الcomplication long term اللي it will be reflected as a positive experience, as a negative experience. يعني المريض اللي بيكون young وبيقطع بمرحلة السكر and he end as he took insulin everything, and he end after 15-20 years being with a kidney failure واضطر يفوت على dialysis, it will be a very good experience because he lose the function of one of the main organ on our body, which is the kidney. He will lose this self-esteem. How come? In which way? كيف المريض بيكون عنده chronic disease والى اخره بيفقد السيلف استيم. شو يعني السيلف استيم؟ او الثقه بالنفس، او يقدر يسوي الاشياء بحاله بثقه وبفعاليه والى اخره. لايك وات؟ low hygiene care. excellent. فاذا ما بيقدر يعني يهتم بنفسه وبالنظافه والى اخره، which is at some point يعني it's not a big deal. يعني ما راح it's not the one that we mean, but maybe you mean that يعني in case he is dialysis, in case he has يعني many other complications, he might have low hygiene. Affect appearance. Excellent. And this is what I'm going to talk about it. Affect appearance. What else? Depend on others. ممتازين. يعتمد على الغير. Affect activity tolerance. طيب. This is, we agree with all your point, but here I would talk about very important point that it might happen for the patient who have a long complication of diabetes and the end with kidney failure and under dialysis. As you know that a patient, he might have, because of dialysis, he might have different complication. Like what? يعني شو أكثر بتصير complication بالdiabetes. What a session of a dialysis, for long 2 or 3 times per week, what will happen? نحن الهدف وقت عم نسحب الفلويد patient he is going to lose electrolytes. Yes or no? فإذا المريض شو بصير معه وقتها session of dialysis؟ بيخسر كثير من الالكترولايتس، صوديوم، بوتاسيوم، كالسيوم والى اخره. عشان دائما نحن بعد الدياليسيس بنجرب نعوض له بالكالترات وسوائل والى اخره. مشان نقص السوائل ايش يسوي؟ نقص السوائل بلس كواليتي اوف فود ما بتكون يعني شوي سميكه، بتسبب له كونستيبيشن. مشان هيك مرضى الدياليسيس لو بلاد بريشر اكيد ديزيس دائما بيوطى ضغطهم، بس انا رح اجرب اربطها بموضوع السيلف استيم ما اطلع من النقطه تبعك. ايش بيصير؟ هالمريض وقتها بيخسر الكترولايتس وبيصير في عنده باي ديفولت بيصير في عنده كونستيبيشن. شو بيصير بالكونستيبيشن؟ كونستيبيشن اوقات المريض بضل كونستيبيشن، بجرب يعالجها يوم يومين. if he did not receive a good care او there is no good doctor to follow him، هذا المريض ممكن لانه complication 1 to 3 days ممكن يصير في عنده not treated. هذا المريض ممكن يسبب له فشل بالامعاء. اوكي. فاذا بيصير في عنده جي اي بروبلم not treated. اوقات المريض بيطلع يفوت يعمل عمليه and he will put like a sac او كولوستومي باج. وهذا الشيء بيصير المريض لا شعوريا يتجنب المخاطره، يتجنب يعني going for visiting, to seeing people, to discussing with people, to sit in front of people, to go. عرفتوا كيف يعني؟ شوفوا الموضوع كيف ربطناه ببعضه. فاذا هون بنشوف انه اللونج تيرم دايابيتس اللي هي بتسبب الانكزايتي نتيجتها كثير اشياء. يعني اعطيتكم اكزامبل انه مثلا من الكومبليكيشن اللي هي الدايابيتس والدايابيتس بتسبب الكونستيبيشن، او الدياليسيس بتسبب الكونستيبيشن، والكونستيبيشن اوقات بتضل مع المريض فيو دايز نوت تريتد، بتسبب له جي اي فشل. وهونيك بيضطر المريض يعني او الطبيب بيضطر يفوت المريض على الاو ار ويحط له كولوستومي مشان يريح الكولون، لانه مشان ما يضطر يعمل له كوليكتومي بيضطر يحط له لايك باوتش اور كولوستومي باج. والمريض sometimes he will stay long time, sometimes he will end with colostomy, sometimes it might take few months. بس المهم بالموضوع انه this patient يعني هذا بيسبب له he will lose his self esteem، يعني بيخفف له، بيسبب له قلة الثقة بالنفس وقلة، يعني بيفضل مثل ما تكلمنا لا بيحب يزور حدا ولا يروح عند حد ولا يواجه حد ولا يتكلم مع حد نتيجة هذا الموضوع. وضحت الفكرة يا أخوان؟ يعني وضحت الفكرة اللي عم جرب أوصلكم إياها؟ اكسلنت. فاذا شفتوا كثير من الكرونيك ديزيز يعني من الامراض المزمنه it will end with a lot of complication، والكومبليكيشن بتسبب لنا كثير من المهالك مع الوقت. يعني it will end with اعطيتكم اكزامبل، يعني مريض he started with diabetes، صار عنده كدني فيلر، من الكدني راح على الدياليسيس، من الدياليسيس راح على الكولوستومي، بعدين we don't know. This is a long process and this is what we call مشان هيك and by depression. Excellent. It's not a secret يا عزيزي عبد الرحمن. I agree with you. يعني الله يعين المرضى ويشفيهم جميعا امين، لانه they will end with a depression، لانه it's not easy for a person to be for a years a disease. عم تحكي بسنوات 15 و20 و25 سنة they are a chronic disease. There is no treatment. At least maybe other disease ممكن تلاقي حل. يمكن أوقات مرضى الكانسر they will receive a cure, they will be fine. بس الكرونيك disease عم نتكلم عنها it's patient will not يعني patient he will not يعني ما راح يشفى من السكر. he could control it but يعني كل شيء يعمل انه يجرب يبعد الكومبليكيشن. والsense of isolation والfear of dying. Why؟ ليش دائما كمان يعني he will have the fear of dying، عنده الخوف من الموت. ليش؟ على شو بيعتمد المريض الكرونيك ديزيز؟ انه اكثر شيء بيدير عنده هذا الخوف بشكل كثير كبير. Why do you think؟ long term العجز. What else؟ excellent. هي اللي بدي اوصلها، لانه المرضى يعني وقت بيكون المرضى عنده session of hemodialysis they will be together. يعني it's not like you will come, this is not one day surgery. It's not like disease which is you will come 1 to 3 days. It's not OR 2, 3, 4, 5, 1 months. It's not fracture. It's a disease that it will stay with your life. And all this type of patient, for example, diabetes patient or dialysis patient, they will be in one unit and they will see each other. I remember the same patient, he was sharing that already we start as 20 patients, now already 4 or 5 pass away. They know. And one time they send him to CT scanner, and the next patient he was, I will call it his colleague, his friend on dialysis, and he had arrested. And this is يعني فإذا العنوان السيشن patient experience chronic disease. فإذا already they experience the cases and they see or they saw another patient with the same condition already how it went the decision. فإذا it's a very depressing for them. Now, how we could help them. طيب how we could help such a patient. كيف ممكن نحن we could help يعني such type of patient. كيف نحن ممكن أن نساعدهم هودي المرض، يعني اللي عنده كل الاشياء تكلمنا عنه، عنده الخوف وعنده القلق وعنده البور اكسبيرينس. what will be your role as healthcare practitioner سواء كنتوا nurses أو doctor أو any type, that how we could support this type of patient. كيف ممكن نساعد نحن هيك مرضى أو نوعية من المرضى، كيف ممكن نساعدهم، كيف ممكن نخليهم to improve تحسين الثقة بالنفس والتقليل من القلق والخوف من الموت ومن الكومبليكيشن والى اخره. What will be your role? Tell me. Such support by reassurance. يعني reassured them. Patient education and involvement. Excellent. What else? طيب would you give me example؟ يعني احنا مروا على اشياء يعني by give me example. يعني اذا انت عندك انت you are an ICU سواء كنت طبيب او تمريض او فيزيوت او whatever، كيف بيجيكم you face such cases مريض long term complication وهي is deteriorating وعم تشوفوا انه he has anxiety depression والى اخره، how you could support. Treat them separately, increase family support, spiritual therapists, encourage them to express their fears and feelings. Excellent. والله ممتازين. antidepressant medication. يعني facilitate visit hours. Excellent. شوفي في شغلة جدا مهمة تفضلت فيها الأخت منى. facilitate visiting hours. نعرف إنه we have a limiting hours, limited hours. هيك نوعية من المرضى بالأخص يا أخوان ويا أخوات بيكونوا بالمراحل الأخيرة، يعني بتشوفوا مريض صار في عنده اورجان فيلر وفاة بمرحله السبسس وصار في عنده كثير من الكومبليكيشن والى اخره، هي شو هي اكثر شيء ممكن يعني تو سبورت هم ويجعله اكثر ثقه ويعني تعطيه ثقه بنفس انه يشوف اشخاص ثانيين، الاقارب، الاصدقاء، الاهل والى اخره. طيب فاذا this is very important as ما تفضلتوا giving positive real information. excellent. شو بتقلنا هون positive real information؟ ليش عم تقولوا لي real information؟ why did you mention that we need to provide a real information? why؟ هذه شغلة جدا مهمة وفي كثير يعني بدنا ننتبه لها، النقطة جدا مهمة. we need to provide to the patient a real information. ليش and why and what example of real information like what؟ he has the right to know everything. excellent. impatient مش مريض الكرونيك ديزيز اخ عبد الرحمن، كل المرضى عندهم الحق انه يعرفوا كل شيء، هاي شغله باي ديفولت. excellent. to have a real expectation. يعني I will give you two scenarios. إذا بيجيك مريض and he has a simple fracture while playing football, what will be the expectation؟ شو بتعطوا expectation؟ شو الاكسبكتيشن من مريض he has a what expectation you will give؟ he has a simple fracture cured، يعني all what you need to do maybe he still not play. يعني I want to give you the message following message انه this case you could give expectation. you can tell me يعني you might be under cast for 2-3 weeks, you will be fine after that, there is no problem لانه you have a this is a real expectation. شو راح يصير مع مريض عنده fracture الا اذا صار في complication على 1 or 2 days. اوكي فاذا مثل ما بتفضل الاخ احمد thank you يعني that the fracture will cure and he will play football again. excellent. فإذا هذا الجواب الممتاز هون أنا عندي clear expectation لأنه عندي clear عن الكيس. طيب شو الاكسبكتيشن ممكن تعطوها لمريض الرينال ديزيز وبالاي سي يو؟ what will be the expectation؟ CRRT. Excellent. يعني may continue on renal dialysis. Excellent. يعني هل يا ترى بتقولوا للمريض okay few days you will go back and you will receive the treatment and you will go back like before؟ لا. فإذا I need to have a clear expectation. Expectation تكون لها علاقة on a real patient, real case. ما بعطي false expectation، بالأخص المرضى اللي بيكونوا على هذه المرحلة. However, you can say that you will give continue the treatment, you will receive a session of hemodialysis 2 times or 3 times per week, and you will be fine. والى اخره. يعني and you might have that complication. ممكن يصير في عندك constipation، ممكن يصير في عندك hypotension، constipation hypotension والى اخره. and this will be the treatment. وممكن تصير معرضة كتير للinfection. you need to be careful. and this is the expectation that I am going to share with the patient. Never ever I will have a false expectation. فإذا ما بعطي المريض أنا expectation which is not existing. اوكي، فاذا expectation اللي هي ما بتؤدي it's a يعني I am lying on the patient. هيدي ما بيجوز. يعني I cannot do it on this way. فاذا always we need to have a clear expectation حسب حالة المريض. and this case the long-term diabetes patient, this is the expectation. Okay, فاذا now we will finish with the first session. Okay, do you have any question before giving you like 10 to 15 minutes break, not more? فإذا بنكون خلصنا السيشن الأولى رح أعطيكم بس ربع ساعة مش أكتر. يعني ما بدي أخليكم بريك ساعة، رح أعطيكم ربع ساعة قبل ما أرجع أكمل for the salah time, and if you like to take your coffee for 15 minutes, not more. فإذا بتاخدوا بس ربع ساعة مش أكتر for salah time and break, and I will see you after 15 minutes. Okay. Okay, great. طيب, we will continue with the last 2 sessions that we merged together because يعني to discuss it as one session. And let's talk about in the session that we are going to talk how to care of nursing care, or I will يعني how to care for a patient who has a diabetes or who has a long-term disease. What type of care needed from doctor, from nurses, from healthcare practitioner. I believe that during the first يعني part of the webinar, Dr. Antoine, he discussed with you a lot about what will be the perspective from a doctor care. يعني what the treatment, يعني prevention, and what type needed from a doctor side. In this session, we will be looking after how to manage or how to care of the patient from the other healthcare team. إذا نحن بالمرحلة الأولى تكلمنا from doctor perspective. Now بدنا نشوف نحن from nursing care or nursing perspective and the other care healthcare team. يعني what will be the role in order to of caring of such of the following. يعني بدنا نشوف ايش هي الكومبليكيشن وشو هو nursing care and other healthcare practitioner care مع هيدي بالاخص النيرسينج because they are the front line وهن بيشتغلوا مع هيدي المرضى او مع هيدي النوعيه من المرضى بشكل مباشر. يعني الكير اوف نيرسز بدنا نركز على موضوع الكومبليكيشن. شو هي الكومبليكيشن؟ and you will go to each complication one by one and to see what types of care is required. But then here, as we said, we have a lot of complication that it might be related to a patient who has post complication of a chronic disease. من بيناتها يعني عندنا ال care related to hypertension، يعني مريض ممكن يكون hypertension، ممكن يصير في عنده angina، ممكن يصير في عنده cataract or eye problem، ممكن يصير في عنده renal disease مشاكل بالكلى، ممكن يصير يعني under dialysis، أو ممكن يصير في عنده diabetes foot. وبدنا نشوف كل وحدة من هذه النقاط what will be يعني the nursing role of caring on such type of patient. طيب let's say during the hypertension, during the first phase we went through the hypertension. I will not go through the cause، يعني أنا ما راح أروح على موضوع الأسباب لأنه already discussed. أنا بدي أشوف what will be the care required سواء من الطاقم التمريضي أو من غير طواقم، بما أخص المرضى الذين يعانون من مشاكل الضغط. like what؟ ايش هي المشاكل اللي ممكن تكون نتيجة الضغط؟ يعني what type of care is required؟ hypertension. what type of care؟ ايش هي الفولو اب؟ وايش هي الاشياء اللي بدي انا I need to educate the patient about it، وبدي I need to follow the patient about it. like what؟ بما إذا ركز على موضوع الهايبرتنشن like what؟ ايش موضوع؟ يعني وقتها بيجيكم شخص بيجيك على البرايمري هيلث كير ار يو ار انرس، بيقول لك والله انا عندي مشاكل بالضغط، ضغطي عم يرتفع، شو لازم نسوي؟ بنبلش من البيزك. always we need to start from the basic. lifestyle. excellent. side effects of medication. ممتازين. ايوه. فاذا اول شغله it might be side effects of some medication or lifestyle or جايين على قصه الاخت امجاد المونيتورنج. هذا بعدني انا بدي اشوف ايش السبب من هالمريض دغري. فاذا بدي اشوف انه هل يا ترى there is a what type of lifestyle، family history. يعطيك الف عافيه. ثانك يو. family history، اللايف ستايل، شو نوع العمل، هل يا ترى في كثير من الانكزايتي والستريس like us healthcare practitioner. فاذا what type of activity if she is doing extra activities or there is no activities. and I will this is the one seen by doctor، مثل ما تفضل دكتور أنطون بالمحاضرات seen by doctor، وطلب منه فاذا monitoring of blood pressure for 24 hours. what type of education needed for this type of patient؟ ايش هي الاشياء؟ برجع بقول لكم نحن بهيدي السيشن بدي ركز على موضوع عمل الطواقم الهيلث كير براكتيشنر مش الاطباء، اوكي؟ لانه الاطباء غطينا هالمرحله. ايش هي عمل طواقم التمريضيه وغير التمريضيه بما يخص موضوع اللي عندهم مشاكل الضغط المرتفع. فاذا they need to do like education about relaxation technique. excellent. فاذا how to decrease the stress and the anxiety, how to take a rest. Education about the lifestyle concerning the daily exercising. في كثير من الدراسات بتقول انه المرضى اللي عندهم ضغط مرتفع من خلال ممارسة رياضة المشي 3 days per week for 40 to 45 minutes عندهم صار في control للبلاد pressure for a long period of time. quality of food، انواع الاكل اللي هي السولت ما يكون في كتير وينتبه من قصة الوزن الزائد، لأنه كل ما يزداد الوزن كل ما يصير البريشر وإلى آخره. proper way of taking BP. excellent. when to position ناخدها ب2 side. what are the signs and symptoms related to high blood pressure and what to do like what؟ من شو بنخاف؟ and organ damage. قبل الاند organ damage اختصارها. bleeding نتيجة ايش؟ ايش هي اهم complication related to hypertension؟ stroke. thank you. stroke. فاذا كثير مهمه انه بدي اقول للمريض انه بدي انتبه من علو الضغط. شو هي علامه الضغط المرتفع severe headache والى اخره, and he needs to go to the nearest hospital as soon as possible and he need to take the medication لانه بنخاف من الهيموراجيك ستروك. بنخاف الستروك تكون نتيجه الهيموراج النزيف. مشان هيك نحن موضوع ستروك كثير ذات أهمية, لأنه وقت المريض ليش بنتطلب as per the stroke protocol وقت المريض يوصل على الطوارئ, ورغم اني متاكد انه صار في عنده ضغط مرتفع وادى الى ستروك, انا مجبور سوي سي تي برين او سي تي سكانر, ومجبور as per the protocol within 25 minutes من وقتها بيصير في عنده عوارض ستروك سوي السي تي سكانر, ومجبور خلال 45 دقيقة طلع الريزلتس, لأنه أنا مجبور حتى لو كنت عارف إنه في ارتفاع بالضغط إن هيموريجيك ستروك, بس أنا بدي أحدد النوع ستروك لأنه ممكن تكون اسكاميك وممكن تكون هيموريجيك. بساعتها لأنه بيختلف العلاج اختلاف كلي حتى لو كان ستروك, بس الاسكاميك ستروك نوعية وطبيعة العلاج تختلف بشكل كلي عن النوع الهيموريجيك ستروك. فإذا this is for the now in case your patient صار في عنده hypertension وصار في عنده stroke وصار في عنده weakness, what will be your role as nurses and other healthcare practitioners؟ بعد بموضوع ال long term complication والcomplication تبعها, what will be your role؟ مريض اوريدي عالي الضغط عنده وصار في عنده ستروك خلص, وصار في عنده weakness be one side of the body, what will be? Physiotherapy. What else? Advice for physiotherapy. Blood pressure control. What else? Rehabilitation. Excellent. Physiotherapist, rehabilitation, control of blood pressure. Lifestyle modification. Excellent. ممتازين جدا. Manage other causes. ايش غير؟ diabetes. في نقطة جدا مهمة. هلا شوفوا عم ركز على موضوع الهايبرتنشن, اوكي؟ ايش هي الريسك ريليتد لمريض كان عنده هايبرتنشن وصار في عنده complication هي ستروك, وانا شو الرول تبعي على الهيلث كير براكتيشنر والنيرسينج؟ I need to work on the risk related to the stroke اللي هي ايش؟ مو شو ممكن يصير عند المريض؟ اذا صار في عنده weakness falls. thank you thank you ممتاز اخت عهود العنازي, ممتازه. falls, هذا المريض بصير في عنده impairment, بصير في عنده ما يقدر يتحرك and he has a high risk of falls. برجع بقول لكم انا بدي ركز على موضوع الكير هاي السيشن اكثر مره على موضوع يعني التريتمنت والاسباب والى اخره. وضحت؟ فاذا اكسلنت سبيتش ثيرابي. فاذا بدي ركز على موضوع اللي شو هي الامبيرمنت او شو هي الريسك ريليتد بحال مريض كان عنده كرونيك ديزيز وصار في عنده كومبليكيشن. حكينا الكرونيك ديزيز هي الهايبرتنشن, الكومبليكيشن تبعها ستروك. شو ممكن يصير نتيجه الستروك؟ حكينا انه المريض ممكن يصير في عنده falls. What are how to prevent the falls? Person, how to prevent the falls? Incontinence. Excellent. ممتازين جدا. By assessment. ممتازين. One-to-one assessment. If he's walking, supporting the patient. do not have restraint، شغلة جدا مهمة. فإذا this type of patient they are at high risk of falls. هذه نوعية من المرضى هن خطر السقوط عندهم بشكل كتير كبير، عندهم high risk of falls. فإذا showering and bathing ممتازين جدا، يعني فعلا مشارياتكم جدا قيمة. فإذا هيدي الأشياء فهمنا شو استراتيجيز في هيدي الأشياء اللي احنا بدنا ننتبه عليها، إنه هي ننتبه بالموضوع الفولس والكومبليكيشن ريليتد للفولس. اوكي، وايش ممكن نحن تصير. يعني انا عندي مثل ما تكلمنا كومبليكيشن وفي عندي ريسك ريليتد لهذا الموضوع، وشفت ايش لازم اسوي بكل الحالات عشان امنع هذا الموضوع. excellent. فاذا this is related to the hypertension. طيب ننتقل للموضوع الثاني اللي هي كمان المريض اللي بيكون diabetes for long term وهايبرتنشن، اللي هي مثل ما حكينا this is one of the main chronic disease. هذا المريض بيصير في عنده معرض يصير في عنده angina or chest pain. ليش؟ أول شغلة ليش؟ المريض بيكون of diabetes for long term أو hypertension كتير معرض بمرحلة من المراحل يصير في عنده angina or myocardial infarction or whatever. Why؟ ليش حسب رأيكم؟ vasoconstriction due to macrovascular. إذا وحدة excellent. إذا one of the complication of diabetes إنه بتعمل لي micro angiopathy and macro angiopathy، يعني بيصير في تصلب وتضيق في الشرايين، يعني من بيناتهم الشرايين الأساسي التي تغذي القلب بيصير في عندها تضيق بالشرايين وخثاسة بالشرايين، وهذا الشيء بمرحلة من المراحل المريض or not able to provide the patient with enough، يعني ما بتوصل له enough supply of oxygenation and you will end with angina. طيب برجع بقول لكم كمان حكينا عن موضوع الانجينا، بدي فوت معكم بالكير. اذا بيجيكم اي شخص بيقول لكم انا بالبيت، او اي شخص بيقول لكم والله انا يعني yesterday كنت نايم ولا عم سوي اي شيء وحسيت مثل عبء على صدري او وجع بالصدر for a few minutes and it's gone. what to do؟ شو نسوي؟ رح امشي معكم للنيرسينج كير من هنا للنهايه تشوف بكل مرحله شو الرول تبعنا. شو المرحله؟ اذا اجاك انها بعدنا بالبيت، بيجيكم مريض بيقول لك انا امبارحه يا كنت نايم بالبيت، لا يا حركه ولا شيء، حسيت مثل وجع صدر لمده دقيقتين ثلاثه وبعدين اموري كويسه الحمد لله. what to do؟ history، duration، type of pain of duration، examination. this is what you will do. this is your answer. risk certification. what else؟ برجع بقول لكم نحن بعدنا بالبيت. اوكي، يمكن اي حد من الاهل، من جيرانكم، من اصحابكم، وات ايفر. what will be your answer؟ اكسلنت، هيدي اللي بدي اوصل له. اول شغله بلا ما اسال عن الهيستوري ولا بسال عن السبب ولا بسال عن الراديشن ولا timing، the first things I will tell him go now to the nearest hospital. هذا الجواب السريع. اوكي ناو بعدني بالكير. فاذا انتم كاب هيلث كير براكتيشنر يور رول جاست تو سند. وصل المريض على الامرجنسي او على الترياج، which category of triage you will put him. Just for your attention, عندنا 5 category of triage اللي هي level 1 اللي هي resuscitation, level 2 اللي هي يعني 10 to 15 minutes to do everything, level 3 اللي هي 30 minutes, level 4 45 minutes هيديك 1 hour. Excellent. فإذا category 2 اللي هي بتعني يا أخوان يا أخوات إنه أنا I have 15 minutes to do everything، مش 15 minutes منشان خلص مع المريض أو تبلش مع المريض. أنا I have 15 minutes to do everything. What needs to be done؟ فإذا I'll put as category 2 and what will be the nursing care during this 15 minutes. بنبلش ECG. Okay, what else؟ قبل ال ECG حتى proper positioning of the patient. فإذا proper position of the patient, semi-sitting position, oxygenation, 12 lead EKG, nitroglycerin, aspirin, taking a blood lab, and the close monitoring of the patient. فإذا هيدي قال النيرسينج كير. شفنا النيرسينج كير بمرحلة إنه المريض عنده الكرونيك ديزيز وفجأة هو ما عرف، حتى أنتم ما عرفتوا بلا ما تعرف كرونيك ديزيز شو ما كانت، مجرد ما يصير عنده chest pain. والنيرسينج كير على مريض صار في عنده انجينا، سواء بغض النظر نتيجة الكرونيك ديزيز ولا مش نتيجة الكرونيك ديزيز، we will follow the same line of triage and treatment. اوكي. فاذا هذا المريض taken to the history. فاذا during we resuscitate انا اعطيته nitroglycerin واسبرين and now my patient he is okay. What will be next؟ شو next؟ close monitoring your patient is okay والى اخره. what will be the يعني كيف تتصور العلاج حيكون بعد هذا؟ depend on the ECG. باي ذا واي الاي سي جي هو يعني ما بيغير وقت يكون في بيك او عرفتك وقت بيكون في يعني بيشن هي سفرنج. اوكي. بالحالات اللي ما بس ممكن الاي سي جي بالوقت اللي مريض هيز اون ذا شوك بعدين مشي الحال. اهم شيء هون after stabilizing the patient انا عندي مريض بدي ارجع على الاوريجن، ايش هي الاسباب اللي ممكن تكون سبتني او سببت هذا الموضوع. برجع على الاوريجين، بعرف انه المريض هو diabetes وصار في عنده angina. What will be the next step do you think؟ Anticipating factors. Excellent. What will be the next step؟ Excellent. شفتوا كيف ممتازين. أنا عم جرب نمشي على strategies بشوف الكير مع المريض على اللونج تيرم ديزيز من وقتها ما بيكون برا المستشفى للحين ما يخلص كل شيء. مثلا here he needs to be seen by cardiologist. ليش؟ لأنه هذا المريض اللي هو diabetes عنده angina ممكن يبلش يصير في عنده الكومبليكيشن اوف diabetes اللي هي ماكرو انجيوباثي اللي هي انسداد وتصلب الشرايين الصغيره الكبيره، وممكن هذا الشيء يؤدي انه المريض he might end with a open cardiac surgery لانه صار له 20 سنه عم بيعاني من مرض السكر وفي عنده مشكل بالشرايين وشرايين الرجل وشرايين القلب والى اخره، وصار الوقت ينعمل له open heart surgery. فإذا this is cardiac cat and والى اخره. فإذا excellent. This is all we call it. شفتوا يعني أنا عندي الكرونيك ديزيز وبتوديني لكومبليكيشن وريكفري اور باس اواي اور ريكفري اور وات ايفر، وشفنا انه قديش اهميه الرول تبعنا خلال كل هذه المرحله. فاذا this is the your proper role or the proper role of healthcare practitioner during in case your patient he has انجينا. اوكي، فاذا هون بنشوف شو الرول تبعنا in case your patient has angina، يعني how he might end with this. This is very يعني كتير هيدي من الكومبليكيشن يعني بتصير كتير عند المرضى اللي بيكونوا diabetes على long term disease. بتصير كتير من complication وإلى آخره. طيب moving forward to the third complication. فإذا واحدة من الكومبليكيشن كمان اللي ممكن تصير أو ممكن يعني تبين عند المريض ألا وهي الكاتاراكت. شو هو what will be your role and شو النصيحة اللي بتعطوها للمريض what will be تسلمي يا أخت عهود كلك ذوق الله يخليكي. طيب الكاتاراكت بدنا نشوف يعني الكاتاراكت. خلينا نشوف يعني بدي ارجع على نفس استراتيجيز. انت ممارس صحي، ما رح فوت بموضوع الاول تكلمنا عنه ايش الاسباب والى اخره، ما بدي فوت يعني كيف بتصير الكاتاراكت. انا بدي اشوف انه انت كممارس صحي بيجي لعندك الشخص او بيجي لعندك المريض او بيجي اي شخص بيقول لك والله كيف بدي ارتب موضوع اللونج تيرم ديزيز وشو الكومبليكيشن وشو الرول تبعي. طيب اذا بدنا نرجع شو علاقه الكاتاراكت باللونج تيرم ديزيز وشو هي الديزيز اللي ممكن تؤدي انه المريض يصير في عنده كاتاراكت. اكسل. فاذا ممكن تكون it can be due to the age excellent. بس هون يختمونا عم نجرب نحن نعمل فوكس على الموضوع على موضوع الديزيز ممكن تؤدي هيك. فاذا ممكن تكون يعني الهايبرتنشن يعني اجمالا هي الاقرب شيء يعني هي موضوع الديابيتس. اذا hypertension complication at some point مش like a diabetes. فاذا one of the main cause that it might lead that the patient he will end with cataract is the long term uncontrolled diabetes. طيب اوكي، فاذا long term uncontrolled diabetes اللي هي بتؤدي انه المريض يصير في عنده كاتاراكت. اذا بيجيك مريض and he is diabetes patient أو and he will tell you I cannot أو بحس مثل ما بقدر أشوف بعين من عيني عين اليمين. What will be your role as healthcare practitioner؟ أو بحس مثل غبش ما بقدر أشوف بشكل واضح بعين من العينتين. What will be your role؟ إيش نسوي؟ Home modification. Check diabetes. أوكي. إذا أول شغلة هون شوفوا في شغلة كتير مهمة لازم نتكلم فيها. هون أنا بدي ميز بين الكاتاراكت وبين التو ديزيز اللي انعملت اللي قطعت معنا اللي هي الانجينا والهايبرتنشن. إذا مريض بيقول لك أنا عندي هايبرتنشن فإذا the first action بتقولوا له go to the nearest hospital. Angina, what you will do immediately you will tell the patient now go to the nearest hospital. الكاتاراكت it's urgent. اذا المريض بيقول لك انا ما عم بقدر اشع بشكل كويس it's emergency. No. فإذا this is the one. بس في نفس الوقت بهيدي الحالة إيش الفرق بيناتهم؟ إنه this one it required more investigation. ليش؟ بالهايبرتنشن والديابيتس ما في investigation من قبلنا immediately to the hospital. هون في فرق، بدي أتأكد من المريض أسأله، لأنه في فرق كتير كبير. وقت المريض بيجي بيقول لك أنا ما عم بقشع بشكل كويس، بلخص بعين اليمين، وقتها بيقول لك أنا وهذا هالشيء حسيته جراديولي، يعني من شهرين كان نظري أحسن. يعني هيدي الاشياء بدي استفسرها مع المريض، بيقول لك انا ما عم بقشع بشكل كويس، اسالي له من امتى، بيقول لك والله انا من شهرين كان نظري احسن من الحين. My vision 2 months ago it was better now. In this case it's not emergency. You could tell the patient no problem, just book an appointment 1 to 3 days to be seen by ophthalmologist. In case the patient will tell you suddenly now I lost totally my eye. This is emergency or no? This is emergency or no? Sudden emergency. شفتوا؟ يعني this is the difference. أوقات بنفس الكيس بعد الكيسات diabetes hypertension stop emergency. بعد الحالات like الكاتاراكت أو بعد الاي بروبلم بدي أعمل assessment قبل ما أقول للمريض تصرف. إذا بيقول لي بلش يصير في عندي ضعف بالنظر تدريجيا ما emergency. إذا المريض بيقول لك الحين فجأة بطلت أقشع بعيني نهائيا، فإذا this is a top emergency. why؟ لأنه ممكن يصير في عنده retinal occlusion. ممكن إيش؟ نتيجة الديابيتس، أو ممكن يكون نتيجة الستروك، أو ممكن يكون أي نتيجة بيصير في عنده، أو امبولي whatever بيصير في عنده انسداد بشرايين العين. مشان هيك المريض فجأة ببطل يقشع بشكل كلي. You got my point. فإذا here you could see in one of chronic disease اللي هي الكاتاراكت بدي ميز انه هل يا ترى هل موضوع gradually والى اخره. طيب فاذا let's say انه انا المريض I advise him to go for ophthalmologist and he went for ophthalmologist وجلس معاه and he what will be the care. He advised him that he has a right eye cataract. شو هو الكير بلان that would you advise the patient after the identification of the case؟ بعد ما عرفنا انه عنده الديابيتس او عنده الكاتاراكت، شو هو الكير بلان اللي المطلوب ينعمل بعد ما شخص حالة الكاتاراكت نتيجة long term diabetes problem؟ follow up regularly. وايش غير؟ the question now already the patient seen by doctor and he put him the diagnosis as right eye cataract. What will be the next plan and what are the next follow-up required for this patient, especially he has a diabetes? Surgery, diabetes control, excellent. أهم شغلة just he need to control his blood sugar. Excellent, good question, good answer. Retinal check, what else? خلينا على موضوع الكاتاراكت. فإذا one of the advice that the patient now he has a cataract that he is due to diabetes. Now we might do surgery after 1 month and or now, and you will advise that he or for sure there is high possibility or 100% he might do later on the cataract operation for the other eye. اوكي فاذا this is very important. بحطوا المريض with expectation انه يعني he might need to do surgery for the other eye. بالdaily life what will be your assessment and education؟ شو بطلب منه لهالمريض on a daily basis؟ avoid the sun cause aggravate. excellent. يعني بدي إيه؟ excellent ممتازين. شو risk related غير؟ excellent ممتازين. we need to be careful with the driving because high risk عنده عين يعني ممكن عين عملي والتاني ممكن يكون ما عم يقشع فيها ومش حاسس بعد. كثير بتصير انه وقتها بينعمل ممكن تقوى العين انت بس كمان ممكن يكون فيها ضعف كثير والمريض ببطل يقشع بشكل كثير منيح. فاذا بدنا ننتبه كثير على موضوع الدرايفنج and to advise the patient do not drive لانه ممكن يكون يعني he might be another يعني this is another ممكن يصير في عنده risk انه car accident والى اخره. Great, excellent question, excellent. Third one, renal disease. This is a big chapter. Renal disease. What will be the patient? What will be your advice for your patient in case he had a renal disease? What will be your role as healthcare practitioner if you are working with a patient who has a renal disease? هذا renal disease. مريض عنده سكر على فترة طويلة من الزمن وفجأة وصار في عنده مشاكل الاكسنت. فإذا بدي أهم شيء بهذه الحالة I need to advise a patient about the signs and symptoms that the patient about the renal failure اللي هي starting with the basic things till the advanced one. يعني بدي بعلمه وادلي على العلامات الأولية اللي بتشوف إنه بتدل إنه المريض صار في عنده الفشل الكلوي. ألا وهي أبسط شيء اليورين أوتبوت. يشيك كل يوم نوعية قديش كمية اليورين وقديش إذا في باد سمالت إذا في الكمية وإذا عم يقدر he's urinating in a جود واي والكميه هل يا ترى يعني اذا كان مثلا من اسبوعين عم بي هيز يورينيتنج 50 ml هذا الاسبوع هل يا ترى بعده نفس الشيء ولا نزل صار يعني اذا اليورين اوتبوت از decreasing and ممكن I might advise him just to give يعني بعطيه يعني just urinated وبيكون معلم بتعرف قديش اذا هالموضوع عم بيخف عنده يعني يورين اوتبوت عم بيخف. هي اول شغله يعني هيدي البيزك things. تاني شغله بساله هل يا ترى عم بيحس تورم بالجسم وبالاخص جهه الرجول يعني هي هاز بتحسي انه المريض هي هاز اديما عم بيعبي مي عم بي هيدي كمان يعني هيك. ثالث الشغله انه if he has the blood pressure is under control هل يا ترى عم يعلى الضغط عنده عم يوطى الضغط عنده. والشغله الرابعه هي الديابيتس او البلاد شوجر. فاذا يعني بدي بلش بالاشياء البيزك اللي ما فت بعد بالانفستيجيشن. يعني دائما انا المريض اللي بيكون عنده رينال ديزيز بدي شيك معه انه على اليورين اوتبوت، وعلى الجنرال اديما، وعلى البلاد بريشر، وعلى البلاد شوجر، قبل ما فوت بالاشياء الادفايس. فاذا انا هون برجع بقول لكم عم بركز على الرول اوف هيلث كير براكتيشنر. وضحت؟ فاذا this is the first things that I need to be careful about. طيب what will be the advanced one؟ فاذا هون بيقول لك المريض انا لاحظت انه عم يصير في تورم بجسمي وبرجولي بالاخص، ولاحظت انه كميه اليورين عندي عم بتخف بنسبه نصف ما كانت قبل من اسبوعين او من اسبوع، وبلاد بريشر على طول عم بيكون في ارتفاع، والبلاد شوجر اندر نوت اندر كنترول. وات ويل بي ذا نيكست ستيب؟ اكسلنت. فاذا هون go to the hospital for further investigation. وابسط شيء انه اعمل الرينال بروفايل، بعمل يعني الكومبليت بلاد انفستيجيشن وبعمل الرينال بروفايل اللي هي سبيشالي اليوريا والكرياتين والجي اف ار. اوكي ذس از بدي تشوف عمل الكلى. منشان هيك طيب هذا المريض على فتره من الزمن ولونج تيرم دايابيتس بيشنت، وبلش عنده هيدي العوارض، راح على الهوسبيتال وعمل البلاد انفستيجيشن حسب ما طلب منه الطبيب، وبين عنده انه في اليوريا والكرياتينين in a very high. It's a very high. What will be next؟ شو سوي بعدين؟ اوكي فاذا to be seen excellent. فاذا here قبل الدياليسيس مش على الدغري، فاذا to refer to nephrologist. فاذا بده يروح على nephrologist يشوف proper or assessment، تشوف هالمرة كم طبيعة عمل الكلى، وكم الكلى يعني قديش نسبة الفانكشناليتي تبعها من خلال اليوريا كرياتينين وجي اف ار، وكثير من الانفستيجيشن الالتراساوند كدني التراساوند والى اخره والسيتي والى اخره، تيشوف انا طبيعه وقديش الكدني او الكلى عم تعمل بشكل مضبوط او ضئيل والى اخره. طيب فاذا seen by ophthalmologist there is order by ophthalmologist انه start this patient we need to go for hemodialysis. What will be the next step؟ as per the nephrologist, now patient he needs to go for hemodialysis. Education on what? Preparing. Excellent. Yani education on the preparation. What? But then here we need to sit with the patient and explain to him how, because there is a preparation needed for hemodialysis. Okay? But then there is a complication or preparation needed for hemodialysis. Like what? Excellent. Line insertion. فإذا here I need to instruct the patient about the importance of a line insertion. لأنه بدي AV fistula. Excellent. فإذا for the AV fistula, the importance to create AV fistula بعطي the proper education that he needs to go for surgery and to create AV fistula, because the situation يعني of the patient now it's not like before. Now لا مهرب من غسيل الكلى، لانه اذا المريض بدنا نشرح له هون ما بقى في، بدي اعطيه كلير اكسبكتيشن انه المريض بحال ما انت غسلت كلى وما قدرت you might end يعني with the time with septic shock and you might pass away. فإذا أنت أحكي لأنه في كتير مرضى بيقول لك أنا ما بدي غسل وإلى آخره. we need to have a clear expectation. بنعمل الفستula وبنراقبها على فترة من الزمن قبل ما نبلش مرحلة الغسيل الكلوي. إذا شفتوا كيف الديزيز from the chronic disease بتصير بتجر بعضها، بتصير من مكان لمكان. اوكي، فإذا this is we need to هون الرينال disease. طيب كمان with good hygiene أكيد، لأنه بدي انتبه يعني بموضوع مثل ما حكينا هيدي it's a invasive procedure. invasive يعني it's a open invasive، يعني it's invasive وكثير المريض لأنه المريض هو already immunocompromised وعنده الفستلة، وممكن يصير في عندهم عرض لكل أنواع الانفكشن والديزيز وإلى آخره، وهيز already immunocompromised. فإذا we need to be careful about this patient. بدنا كثير ننتبه بموضوع إنه we need to be careful by looking after this patient. طيب كمان this patient now he end with dialysis. How to prepare for patient with dialysis. Now حطينا الفستولة already. اوكي، ما بقى في مشكلة، حطينا الفستولة. How to prepare for dialysis. What kind of preparation it's needed for you as healthcare practitioner during the first session of hemodialysis. Excellent. Psychological preparation. ممتاز أخ عبد الرحمن. يعني حسب رأيك زي إيش؟ شو هي psychosocial preparation or psychological preparation like what? commitment. يعني بدي اشرح له بزي كتير اكتشف انه انت الحين حياتك ونمط الحياة تغير. بالاول نبقى نطلب منك انه تكون بالبيت وتنتبه على الضغط وتنتبه على السكر وتيجي بالمستشفى حسب الحاجة. الحين تغير الموضوع، مطلوب منك التزام كلي بانك تسوي 3 مرات بالاسبوع جلسات غسيل كلى، والا بيكون في خطر على الحياه، لانه نشرح له انه عمل الكلى هو زي مصفاة الجسد، وبحال ما في تعطلت هذه المصفاة انت كل الويست رح يصيروا بقلب جسمك، وبدل ما يطلعوا لبرا بالحالات الطبيعيه الكدني بالحالات الطبيعيه هي بتطلع لبرا. بهالحاله انت الكدني ما عم تشتغل، رح يكونوا مكدسين بقلب جسمك، وهذا الوقت بسبب لك تسمم. هيدي اللغه اللي بدي اتكلم معها فيها على المريض very easy way، وبشرح له اياها بطريقه جدا مبسطه تيعرف المريض، لانه متى ما يفتكر المريض انه موضوع الدياليسيس مش موضوع البلاد شوجر والهايبرتنشن، بيجلس على البيت وبياخذ الاحتياطات وبياخذ الانسولين اون تايم والبلاد بريشر اون تايم بيمشي الحال. لا، هون متطلب الكوميتمنت. يعني نقطة جدا مهمة يا أخ عبد الرحمن، commitment، الالتزام الكلي بالسيشن اوف dialysis. طيب this is يعني as preparation for the patient. during the first session اجى المريض فات على قسم غسيل الكلى وبدي بلش انا اشرح له او اتكلم معه. شو ال preparation needed or what are of education or how to start the first hemodialysis session with the patient. ايش يعني hypothermia؟ excellent simple explanation about the، يعني مش دغري المريض. شوفوا هيدا من الناحية بعد عن نحكي على الاكسبيرينس، يعني المريض بيكون عنده خوف من هذا الموضوع، فجأة تيجي تحطه على ماشين وما يعرف فيها ولا سامع عنها ولا شيء. فإذا أول شغلة أنا في شغلتين بدي أشرح له إياها. كيف هالماشين the proper way on how this machine it's working، يعني كيف هيدا الماشين تشتغل. بدلي إنه this is how to take the blood inside the machine. بفوت بالماشين بيتنظف الدم وبيطلع بيرجع بفوت على جسدك من خلال هيدي السيركت. فإذا هون I need to have a very simple، يعني بشرح له كيف عمل الماشين انت مشان يطمن ما يحس انه هيك. وبشرح له انه اهم شيء انت في عنا we have what we call the optimal weight، في عنا وزن مفروض نحافظ عليه، وهذا هالوزن كل شيء بيجي برات هذا الوزن بدنا نشيله. يعني انت بين سيشن وبلاش سيشن، اول سيشن اخذ لك الويت الاوبتيمال ويت 80، جيت لعنا وزنك 83، في لازم يشيل لك 3 كيلو. وزنك 84 4 كيلو which is كتير too much for you، ممكن يصير لك complication. منشان هيك dialysis ما بيعني انه ناكل كل شيء، we need to control our weight مشان ما نضطر نسحب لك كتير من السوائل. وبتعرف اذا نقص عندك البوتاسيوم، اذا نقص عندك الصوديوم، رح يصير في كتير من الكومبليكيشن. This is the way. يعني I am simplifying now how we need to explain to the patient. هيدي هي الطريقة اللي بنشرح فيها للمريض. اوكي، وشو بعد لازم نشرح له؟ فاذا هون واخذنا له وزنه وبلشنا والى اخره. شو بنشرح له على الكومبليكيشن ريليتد تو داياليسيس؟ شو هي الكومبليكيشن ريليتد على هذا الموضوع؟ لايك وات؟ الكومبليكيشن ريليتد تو داياليسيس. ايش ممكن يصير المريض اثناء الجلسه؟ excellent epilepsy or central line associate because he has a catheter. and لانه دائما insertion he might have a central line or epilepsy central line infection. Bleeding from the side. Excellent. What else? Bleeding, one of the main complication. What will happen during the session? What might happen during the session? Hypotension. Excellent. Present patient, he might have a hypotension. What to do in case your patient has hypotension? Stop the ultrafiltration and infuse saline, electrolysis. And which position you'll put the patient? Leg up. Oh, excellent. For more blood flow. Excellent. And this is what we need to instruct the patient about what might happen during the session of hemodialysis. Now, patient, he finished the session. Now he is going home. What will be, what kind of operation it's needed for this patient? And what type of education or support needed for this patient? After the session. what do we need to instruct the patient? Antihypotension. Educate the patient regarding the care of the catheter. Excellent. Very excellent. Care of catheter. Rest. Do not drive. Do not drive by himself home. اوكي يعني ما يسوق السيارة بمفرده لأنه منشان he might ممكن يصير في losing control ويصير في عنده car accident. About the food, type of food that he need to take. When to report back to the patient, to the doctor. And then this is all that the patient he needs to know or he needs to be instructed on. But then as you see, this is the proper role of healthcare practitioner on dealing with the patient who has complication of a long-term disease, like as we said. طيب. And the last part that we would like to discuss it, which will come after a long time of diabetes disease, which is the diabetes foot. The last part that we are going to discuss it, هي موضوع that it will happen as the end, at the end stage of the or the last stage, I would say, of the complication of dialysis. And usually the patient after complication of dialysis مش تغري he will not go direct to diabetes food. Diabetes food, a lot of statistics, and it was run that it will happen to the patient maybe after 20 years of uncontrolled diabetes food, and maybe it won't happen. And it was very high complication لأنه المريض كثير بيعاني من هذا الموضوع. And what بيصير على diabetes foot يعني خلاص يعني he will be in a very critical condition. But on diabetes foot, first of all, what type of education needed from your side as healthcare practitioner in terms of prevention and management of diabetes foot? Then what type of education and follow-up it's required from you as healthcare practitioner for the prevention and management of diabetes foot? قبل الدراسing يعني before, what do I need to explain to the patient? Risk of the info, any changes, try to avoid injury. Before this, patient in the early stage of diabetes, I need to tell him about this major complication. I want to tell him that, for example, in case you had a cardiac problem, you might have a cure. In pneumonia, you might have a cure for you, but diabetes foot, when it starts, means the prognosis is going to be very difficult and means you are in the latest stage of diabetes. يعني usually it will come at the last stage. يعني المريض usually he will start with cataract problem, then later cardiac problem, then later renal problem, dialysis, and later on after long time he will have a diabetes foot or no. يعني we need to tell the patient that we need to do everything to avoid having the diabetes foot complication. By what? What is the main reason that it might lead for diabetes foot? Excellent. The main cause that will lead the patient to end with diabetes food is the long-term uncontrolled blood sugar, not 1 or 2 weeks. long-term يعني إذا المريض مستهتر وما بحياته رجل السكري ولا شغل على السكري, he might end with this. As a long-term uncontrolled blood sugar, not short-term, long-term uncontrolled blood sugar, it might lead to diabetes. فإذا we need to instruct the patient about the importance. Now, what type of education needed? What he needs to look after قبل ما نبلش بالcare of diabetes food, قبل ما أوصل لهالمرحلة. Diet education, excellent. What type of diet needed? What are the diet needed for this patient? Neuropathy, lifestyle, changing lifestyle. Like what? Give me example. نبلش من الفود. What type of food did he need to أول شيء اتفقنا المين ريزن هو uncontrolled diabetes food, diabetes blood sugar. We need to control blood sugar by following this sliding scale given by doctor. Okay, and take the insulin on time, and to report the doctor in case there is hypoglycemia or hyperglycemia. This is by excellent. To have this is first, and to have a daily walk, to walk across for half an hour, for example, per day, and to follow or to some type of food that diet that it's important for to prevent the diabetes food. Do not eat too much food rich in sugar and low carbs, low sugar. He needs to eat more protein instead of sugar and fat. Okay. And always he needs as our colleague Joe Manashi said that منتظم بزيارته على المطبب, فإذا he need to follow this. Now, what type of signs and symptoms the patient بعد ما فتح بمرحلة diabetes food, what type of signs and symptoms the patient he needs to see on his leg? هالمريض فجأة بيصير في عنده gangrene, but on what type of signs and symptoms needed to be seen by the patient on his leg? Swelling, numbness, pain, infection, redness. Excellent. Changing in color. أول شغلة we need to change the color. إذا صار في تغيير بلون الرجل, أول شيء إجمالا بيكون diabetes food بيكون في it will be very pale, بتحسوا إنه اللون بيكون جدا جدا لون شاحب. أوكي, بيكون لون بتحسوا إنه like there is no irrigation. Okay, or there is no good vascularization. Okay, فإذا there is no vascularization. This is the first sign, and you will instruct this patient that this is an early signs, and we call it like the pressure injury, the early signs or stage 1. Later on, the color it might change more and more, and he might end with a starting to have a black color, and he will start like having a very bad smell and like a pus. Okay, like a pus. And this is now he's moving very quickly from a stage to another stage. He will not go for gangrene directly. He will start changing in color, then changing in the redness, swelling, redness, swelling, okay, and with poor irrigation, and later on not treated or not seen by doctor, not controlled, he might go with the latest stage, which is the amputation or gangrene. Okay, he might go لأنه إذا ما عملنا الامputation or treatment, he might end with a septic shock or sepsis. Okay. And this is what will happen. Now, what will be the treatment? We might have different treatment. Patient, he might go for the Branton OR, or even one of the main treatment that with high impact on the patient. Do you know what is the one of the treatment that nowadays we are using too much for a patient with diabetes foot? Do you have any idea? Like what? Vascular specialist should be consulted. Revascularization by what? قبل ما نروح على الامputation. We will try everything to avoid the amputation. Antibiotics. What else? Did you heard about the HBO or hyperbaric oxygen therapy? This is one of the treatment that it's we are using this we will try everything before ما نروح على موضوع الامبيوتيشن. يعني دائما بنجرب نحن to avoid موضوع الامبيوتيشن لانه يعني بتعرفوا from different side we need to try different treatment different side. Then this is the way how do we need to approach the patient, how do we need to look after the patient. But then here this is all that required from us a proper care or proper as healthcare practitioner. لانه انا كهيلث practitioner في عندنا جزئين. في الجزء الاول مثل ما تفضل الدكتور بالقسم الاول انا بشتغل على موضوع البريفنشن، على موضوع وصف العلاج مشان ابعد عن الكومبليكيشن. فاذا هون بيكون دور الطبيب انه يعطيه العلاج المناسب ويشرح له كيف يمشي على العلاج وكيف يعمل فولو اب والى اخره مشانه. وفي كثير من المرضى بيلتزموا بتعليمات الطبيب بموضوع العلاج وكيف ياخذوا الانسولين اون تايم والى اخره. بيوقف الموضوع عندهم by taking insulin the whole life وما بيصير في عندهم complication. اذا في complication بنكون بالايرلي complication موضوع الكاتاراكت والى اخره very small. بحال المريض ما التزم بهذا الموضوع بيفوت بموضوع الكومبليكيشن صرنا اكثر من ساعه ونص نتكلم عنه بموضوع الهايبرتنشن وموضوع الانجينا وموضوع الاي بروبلم وموضوع الرينال ديزيز وموضوع الدياليسيس وموضوع الديابيتس فوت. هون it will require the care from nurses and different stakeholders اللي هي الفيزيوثيرابيست والسبيتش ثيرابيست والكير اسيستنت و different people that بيعملوا. Here we have another role in the follow up of the patient and the good care. لأنه by having a good care أنا بعطي better chance of life. And remember that we are working with immunocompromised patient. Okay, with this slide we will end everything. Do you have في أي سؤال بتحبوا تسألوني قبل ما نخلص كل شيء على موضوع السيشن سواء اللي يعني بالأخص هودي فاتت بعد الظهر؟ في أي سؤال بتحبوا تسألوني إياها قبل ما نخلص كل شيء؟ هيك نكون غطينا كل الأوبجكتيفز وكل الأشياء اللي لازم تعرفوها خلال هيدي الويبينار. و if you have any question لو سمحتوا ما تكرمتوا معطوني خبر عشان to answer your question قبل ما ننهي كل شيء؟ Then if you have any question, I'm ready to answer you before ending everything. طيب. فإذا we will end. Thank you for your attendance. شكرا لحضوركم. Thank you للorganizing and thank you for the scientific committee organizing that يعني they give us the opportunity to be with you today. وشكرا لحضوركم ونلقاكم إن شاء الله في يعني for another event, another webinar, and enjoy your evening and see you إن شاء الله.